care to introduce yourself, please?
Thank you. I appreciate that. Good morning. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well. Thank you, Senator.
Now that we're getting close to finishing up some of our key committee work, I'll be getting close to figuring out how to do this. So sorry about that. All right. So I think we're on hold for right now while our YouTube connection is being established. We shouldn't really be doing any business, but any catching up that people want to do? Oh, yes, Carrie?
We're good to go. Thank you.
We're good to go. All right. So that gives me an opportunity to allow the folks who keep this committee as organized as it is. It's their fault. And so we'll let Erin Dooling introduce herself.
Well, with that introduction, my name is Erin Dooling. I'm one of the legislative analysts with the Health and Human Services Committee with the Nonpartisan Office of Policy and Legal Analysis. We do not take positions on or advocate for any legislation.
And you've also heard from Carrie Withey.
Yes, good morning. I'm Carrie Withey. I'm the clerk for the Health and Human Services Committee. If you need any assistance today, you can email me at hhs@legislature.maine.gov.
And Carrie's been very helpful in getting people into the right room at the right time. Room being a cyberspace term for in the panelist category or the attendee category. So thanks to them both for that work. So if there isn't anything else pressing that we need to take care of, we could just move right into consideration of LD 62. I guess you did 72 and 996 together also, Erin. So turn it over to you.
Okay, I'm going to share my screen. So I'm sorry that it's probably pretty small. I tried to fit it on one page like for PFAS, but unfortunately I couldn't. So it's on 2 legal size virtual pieces of paper. So LD 62, 72, and 996 all relate to expanding dental health access for the people in Maine who would be MaineCare members. All of them propose to expand MaineCare coverage for full and partial dental dentures and other comprehensive preventive, diagnostic, and restorative dental services to maintain good oral and overall health in accordance with the department rules. LD 72 is different from LD 62 and 996 in this regard because it provides that those services must be medically necessary, while that's not a requirement under the other 2 bills. LD 62 and 996 also require the development of educational materials to be publicly distributed by the department to adult MaineCare members on the necessity of dental care for children and timelines for children's care. MaineCare members aging out of children's coverage who would be eligible for the adult benefit. And LD 996 includes the importance of oral health and reducing health disparities experienced by Maine racial minority, Indigenous, and tribal populations. Similarly, LD 62 and 996 propose to include stakeholder engagement in that public education campaign, to include providers of pediatric medical services and dental services. And 996 also includes community organizations with deep connections to Maine racial minority, Indigenous, and tribal populations. Those 2 bills also include a report back to the legislature within 5 years, both to the HHS and AFA committees, that include the costs of the program, any potential savings realized, and 2 other data categories that 996 proposes to include is the demographic of the benefit utilization, including race, ethnicity, and geography, and efforts to reduce oral health disparities. The coverage is directed to begin by April 1st, 2022 by the department adopting emergency rules under LD 996. There is no specified coverage start date in the other two bills. And so I would assume that that would mean that the coverage would start as of the date that the legislation becomes effective. Under 996, it proposes rulemaking. It specifies what the rulemaking process must look like to implement the expanded coverage requirements. It includes a stakeholder group that the department must convene by October 1, 2021. And the department must submit a plan to the HHS committee by January 1, 2022. And so the stakeholder group includes a variety of people involved in providing dental care or receiving dental care, and that they would be developing a plan that would include dental services, current projected expenditures, anticipated cost savings, reimbursement models, delivery models, an evaluation of reducing disparities and improving education, as well as developing metrics that would determine, that could be analyzed in the future to determine the success of the program. All the bills in some form require the department to work with dental providers to encourage participation in main care. LD 72 specifically proposes a $1 million annual dental incentive to be adopted by emergency rule by the department no later than January 1, 2022. With the input of the working group, and the goal of that incentive program would be to reward dentists who significantly increase the number of main care patients or to provide dental care to a disproportionate number of main care members. The working group would be convened by October 1 of this year, and it would include main care members and providers of dental health services, as well as other people with policy experience in promoting access to dental care. The fiscal impact has not been determined on any of these bills. You received some information from the department about their current evaluation of rates. There was also some concern that the timeline proposed in 996 about the stakeholder group in combination with the duties required and engaging in rulemaking and the application to the department is in a timeline that's likely to be achievable. And you had asked that someone be at the work session to address those timeline concerns. And I think Molly Bogart is here. You received a suggested amendment for the testimony to ensure that the bills wouldn't be limited to, I wasn't sure in which specific area of the bill this feedback was directed, but that if dentist is used, just to clarify that really any dental providers who would be main care providers would be included, such as dental hygienists and dental therapists. And then as a drafting consideration for you, you may want to consider including legislative authority to report out legislation upon receipt of either the stakeholder reports or the reports from the department, depending on which bill we're talking about.
Okay, does that raise any questions for the committee? That analysis. All right, welcome, Senator Baldacci. Would you care to introduce yourself?
Sure, thank you. I'm Joe Baldacci. I represent State Senate District 9, which is the city of Bangor and the town of Herman. Thanks.
And I see that one of the sponsors has joined us. Welcome, Representative Brooks. Did you have any questions after hearing this analysis?
Yeah, it was a really very great analysis, and I believe, you know, the attention the bills are getting is really important. That's what I would stress, is just how critical the need is, how many people are suffering, and how it would save money in the long run. The prevention and addressing these issues as early as possible would really help relieve pain and suffering, and would really help lower the costs overall. And we, you know, we heard a lot of powerful testimony from a lot of different participants in the public hearing. So I really appreciate your taking a deep dive into consideration of these bills. And I think there were a lot of improvements in LD 996 to consider, and I would favor including those provisions where the bills differed from each other. I believe that's really, really important as well.
Okay, thank you. Representative Javner?
Sorry, get myself unmuted here. Thank you, Senator Claxton. Appreciate that. I just have a couple questions, and I think maybe Molly might have the answer for these. I'm looking for a little bit more detail concerning the incentive program piece and why it's capped at 1 million, where we arrived at that number. And then also, how many dental practices are we talking about here that actually provide main care services? I know there are actually many in our area here that don't provide those services. So I'm curious as to what the difference is.
Molly?
Sure. Good morning. I'm Molly Bogart, Director of Government Relations for the department, and actually Director Probert is in the participant list as well. And so
Great.
it would be great if we could add her. I missed the beginning of your question in the transfer. So if you wouldn't mind repeating that the first question, that would be great. And I expect Michelle can help answer.
Great, no problem. Thank you, Molly. It's good to see you this morning. I'm looking for just a little bit more detail about the incentive program that is included in this bill, and it's capped at 1 million. I'm wondering how we even arrived at that amount, and really what an incentive program really looks like.
Sure, and Michelle can certainly speak to it, but that might be a better question for the sponsor.
Yes. Yeah, that's really Representative Brooks to answer the $1 million question to start with. Let's
Okay,
start
great.
there. And can you speak, Representative Brooks, as to where that number came from?
Well, I took that number from the previous bills that were submitted last session. And I think that that's a huge issue in Maine, or I'm sure across the country as well, that the number of providers that accept main care, or if they do accept main care, they might have a limited percentage of their patients that have main care. That's a really, really large problem that we want to try to help incentivize payments and reimbursements for services provided. But the more people, the more dentists and dental hygienists. I would also favor including other dental providers like the hygienists and others to participate as well. But I think part of the reason that people don't participate has to do with the reimbursement, and that's really a big gap in our current system.
So I'll defer to either Representative Probert or Molly in terms of trying to answer the number of dental practices out there that accept main care patients. Who wants to go and answer that one?
I think you just
Welcome.
elevated me to an elected official, which I am not. But I will, unless Molly happens to have those numbers on hand, I will need to get back to you. I'm chatting with my team, but we'll need to look into those numbers. I don't have them offhand.
Okay. Molly, is that something that you carry around in your head?
It is not, unfortunately.
Okay. All right. Let's see. Senator Baldacci.
Thank you, Mr. Chairman. Was there a fiscal note to, I'm assuming these bills are similar to the bills submitted in the 129th. And were there fiscal notes attached to those bills that might be helpful, or does Ms. Probert, couple of things. I was wondering if there was any estimates on how much this would cost. And also question 2 is, how many people would this most likely benefit? Do you have any estimates about that?
So I would look to others. I'm not sure why a fiscal hasn't been submitted for these bills yet this session. The fiscal would probably be similar to what was submitted last session. I did want to remind the committee that the department is currently working on proposals to implement the recommendations from our comprehensive rate system evaluation. And a reminder that one of the recommendations of that report was to increase dental rates. Our dental section of policy was identified as one of our sections of policy most in need of investment in rates, generally speaking. So the legislature will have budget initiatives fairly shortly. And so I just wanted to note that that a change to current dental rates would certainly result in an impact to the fiscal of this bill as well. And I can circle with my team, Molly and I can circle back with a team to see, to get those numbers to you.
And I just want to point out that this Director Probert is the head of the Main Care Services Division. So we skipped some of the intro. We all know her. Erin, did you have your hand up?
Just wanted to circle back to Representative Jabner's question about the incentive program and how that would be developed. The bill provides for a stakeholder group that would design what that program would include, and whether that's changes in reimbursement or something else. I think that the bill doesn't specify exactly how what the program would be look like, which is what the stakeholder group is for.
Okay, Representative Lemelin, you had your hand up.
Yes, thank you, Senator. My question is for the director. Am I mistaken here? I thought that Maine children on Maine Care already receive the services of dental care, and that it's only once they become adult that they lose it. Am I wrong there?
You are not wrong. That is correct.
So my question is, why do these bills include Maine children and adults with low income instead of just the adults?
Is that something you want to speak to, Representative Brooks?
Yes, I was going to say, we definitely see it's really important to have the prevention and dental care for children, but it's also a big issue with adults that I'm sure we do have a lot of ER visits. There's a large fiscal note or a large expense in adults as well, going to the emergency room for dental care, having significant pain and suffering, and it is linked to not only pain, suffering, infection, heart disease, but also along with that an increased expense.
I think the question was, why are we including kids in these bills if they're already covered by Maine Care? If their dental services are already covered by Maine Care? That's what I heard Representative Lemelin asking.
I could help answer that question.
Okay, Ms. Del Rio, welcome.
Thank you. I'm Kathy Clarine Del Rio with Maine Equal Justice. So as some of you recall, this is something that we've now talked about for the last 3 years, counting this year. And after our first year, several of our partners we are working with who do a lot of work with children and oral health felt it was important that we be explicit that helping get adults coverage also benefits kids, because there's like a direct connection between when parents have access to coverage and kids getting to see a provider. And then there was also our other partners in the provider world felt strongly too that by covering more people, it actually like strengthens the provider network, because it provides more opportunities for them to have a source of payment when they see patients. So that's why both last year and this year, our bill titles included Maine Kids, because we were trying to respond to what our partners were expressing back in 2019. And then I just wanted to just quickly note about the incentive payment piece that was in one of the previous bills. That was something that we put in because we had seen it used in a model in another state. And we recognized that that it's important to strengthen the provider network. And then after, that was also, I think, in our original bill in 2019. And the reason that we ended up switching to a stakeholder working group model to try to figure out the best way to improve participation was because, again, we had heard from partners who are providers or who work closely with provider networks that they thought that might be a better way to figure out what the best solution is, and totally appreciate what Director Probert has said about the rates, and recognizing that we probably do need to do some work on the rates. And then the last thing I just wanted to say in terms of people who would be covered, the fiscal note for the previous two bills anticipated that it would be about a third of eligible mean adults who would take up this coverage, which in that last fiscal note, I think was about just under 54,000 people. And that data was, that came from like usage in other states that have this coverage already. And it's also referenced in the report from the HPI that I had emailed to you all during the public hearing. And then, so I will note that the coverage right now, there's more people enrolled in main care due to the pandemic. And so I did some quick math, and Director Probert probably would have a more accurate number, but based on data that she shared with your committee earlier this year that said that I think there are about 217,000 adults currently covered back in the fall of this year. And so if we did like similar math, it would be about 65,000 people would be likely to actually take up this coverage. So we don't have the actual fiscal note, but that's my guess of how many people would utilize the coverage in the first few years.
So I think still unanswered is the question of, still not clearly answered, is the question of, does this bill expand services for kids, the pediatric population, in terms of dental care?
Yeah, it doesn't directly expand coverage to kids, except there is information about education for families about the importance of oral health care. And we know that when parents have access to coverage, that kids are more likely to get care, but it doesn't
But on
directly
any
expand
given
anything for kids.
child showing up in a dental chair, what they're going to get wouldn't be any different today than
That's
they
right.
would get with the passage of this bill. I
That's
think we
right.
finally got to an answer on your question, Representative Lemelin.
Thank you. I have one more question, if I could, Senator.
Sure.
Does this bill provide any parameters like limits on dental? Would it be one cleaning every 6 months? Would it include only certain parts of dental care, or is it carte blanche, wide open?
So why don't we get Director Probert to speak to, or Molly to speak to, what current coverage is, because it uses the words restorative and preventative. Do you want to answer the question about what our current coverage is and whether there are limits on that?
So related to that, I wanted to point out that even though Aaron showed that only one of the bills calls out that services need to be medically necessary, medical necessity is a federal requirement. And I believe, and one of my staff is chatting me right now, that we do have parameters on when certain services would be appropriate because of that medical necessity requirement. I do also have information I can share on the fiscal, if that would be helpful at this time.
Sure.
So the estimate for state general funds for LD 996 on the coverage side would be, I'm rounding, but 8.5 million general funds. The total cost, including state and federal, would be 29.2 million. I will share that if we were to implement the recommendations of the rate system evaluation, and again, dental services were think about in last place in terms of how main care reimbursement compares to reimbursement from other state Medicaid agencies and comparing reimbursement to commercial reimbursement as well. So if we were to implement the recommendation from the rate system evaluation, that 8.5 million general fund fiscal impact estimate would increase to 12.3 million general fund. And the total amount, state and federal combined, would increase from the 29.2 million up to 42.3 million. I also just wanted to note that I misspoke earlier, and that I want to be clear that we do provide services to adults in order to cover imminent tooth loss. So it is not correct to say that adults don't receive any dental coverage right now. It is just limited.
Can I clarify, Director Probert, those numbers you gave us, the 8.5 versus 12.3, that's on the assumption of that we retain the medically necessary requirement? That's part of that assumptions there?
Yes. So from a federal perspective, if we want to receive federal match for these services, we have to limit coverage to medically necessary services anyway, regardless of what the language of the bills actually say. So we are assuming that we are just covering medically necessary services. Otherwise, we would have to look at state-only funded, state-only funding for medically unnecessary services.
Thank you. Representative Perry?
Thank you. I just want to ask is, what are the definitions of medically necessary? I guess the question I had is, I had a type 1 diabetes patient who was not considered to be medically necessary to have his teeth taken care of. And I just, my frustration with medically necessary is, what is the determination and who determines that?
Is that something that you could speak to, Director Probert?
I can circle back with a more complete definition of how the federal government defines medical necessity. I think that I believe Representative Perry is speaking to what services an adult is currently eligible for, and so it's a bit different when you're talking about services that we currently cover and what is considered necessary to prevent imminent tooth loss versus if we were to expand to broader preventive coverage. Then when we think about all of our health plans, none of us are allowed to get coverage for going in to get cleanings every 2 weeks, for example. And that's an example that is an exaggeration. But I think that the general intent of medical necessity is to ensure that care aligns with evidence-based practice.
Okay. Senator Moore, did you have your hand up?
I did, Senator Claxton, thank you. And I thought maybe we were going to be answering the question. So I guess in my mind, I'm thinking that if we're talking about preventative dental care, where we go in every year and have our teeth, or every 6 months, I have mine cleaned and checked, that would not be classified as medically necessary. Is that how I'm understanding it, Director Probert?
No. So currently for adults, we offer a rather limited benefit, and that benefit is really just about preventing imminent tooth loss is the phrase. It's often colloquially referred to as emergency dental coverage. Right. So these bills are expanding coverage to adults much more broadly, including what I think we all think of as typical dental care of getting regular cleanings and getting your cavities filled and everything else. Generally speaking, we do not cover those services for adults right now. My point about medical necessity was just that Aaron had showed that in the 3 bills, only one of them specifically called out medical necessity, but Centers for Medicare and Medicaid Services, generally speaking, they try to ensure that states are providing care that is medically necessary and use that as a general caveat for care that's provided. And so that just means that we're not going to start to cover lots of teeth whitening for all of us who wish we had brighter smiles. And again, I'm exaggerating, but it's supposed to make sure that care is kind of best practice and aligned with evidence, and our fiscal estimates assume that we would continue to abide by those federal regulations.
Thank
Is
you.
that-
Representative-
Do we, and one more question, Senator
Sure.
Clarkson. Do we cover preventative services for the children that are on main care?
Absolutely. Yes, we do.
Okay. Okay. I just want to confirm that. Thank you.
Yeah, that's a different definition of medically necessary for the kids than for the adults, because the imminent tooth loss isn't part of the conversation with the kids side. Representative Madigan, do you have your hand up? And then I'll go to Representative Stover.
Thank you, Mr. Chair. Ms. Probert, I'm wondering, you said that current main care coverage for adults in dental care covers emergency treatment to prevent imminent tooth loss. My experience is that much, I mean, I would assume that would mean a filling or a root canal, but my experience has been for adults on main care, what often is only covered is the extraction, which to me is the tooth loss. So, I mean, I guess I want some clarity around that.
Sure, I can follow up with more clarity. What I can say is that we have done a fair amount of work over the past couple of years trying to clarify parameters for what is covered and not. I think that there is oftentimes an assumption that our coverage is just limited to tooth extraction, but it is it is a little bit broader. We need documentation from the dentist and about imminent tooth loss. So there is more flexibility there than is often acknowledged.
So my question would be that if someone has to go to a dentist right now who's a main care recipient to get that evaluation, how is that paid for?
I think
a determination made. Do you understand what I'm saying? Like,
yes,
if they,
I do. Yeah, I would say that the care provider, so whether that's a primary care provider or an emergency room doctor, but a healthcare provider who has has knowledge of what's happening with somebody's dental situation can help provide that information. And I can follow up with my staff who have more in-depth knowledge on this topic to get you an answer in writing.
thank you.
Representative Stover.
I had a question about medical necessity and then something I wanted to respond to. Director Probert, would medical necessity for oral health care for adults include or exceed the threshold of pain and infection, which is often the benchmark that's used now for treatment, which is for adults, which is pain and infection is used?
So I am not prepared to get into an in-depth discussion of medical necessity for adults. I have a whole policy sitting in front of me, but I don't want to read through that right now for you. So happy to follow up.
Thank you very much. And then I just wanted to mention about the children and other questions about children's coverage. Yes, there is coverage for children under main care for a comprehensive benefit, and it's a preventative benefit really. But what kids need and what they actually can get because of Medicaid availability, dentists who take Medicaid and the availability across the state, it isn't always the same. So yes, it's covered, but there's a gap in that coverage because there's not dentists who will take it universally. I just wanted to say that. Thank you.
Senator Baldacci, you've had your hand up.
Thank you, Mr. Chairman. Just a couple of points. I think that one of the things I think Ms. Del Rio had mentioned that should not be overlooked is the fact that this bill will significantly strengthen the provider network for both children and adults. And I agree that the availability of dentists is difficult, but I think one of the side benefits of this, if not a primary benefit, is that you're going to draw in more dentists who will see this as a way to as part of a business model to do business. And based on the numbers that have been provided, I think it will expand choice for families with children as well as for adults. Having said that, I just want to make it clear for the purposes of the record that I believe that healthcare is a fundamental human right. I think that these advances, particularly LD 996, which I think is fairly comprehensive, needs to be passed. And I think, we're talking about 65,000 fellow citizens of this state who will have access to some form of dental care, which will certainly prevent multiple medical problems going forward, will certainly improve the quality of life, will certainly improve their productivity or ability to contribute to society in general. So I'm prepared, whenever the committee is, I'm prepared to vote, but I just want to make it clear that this is an important step forward, that the state has resources both in the Medicare funding, in the main care funding, and in not only the general fund, but in funds that are coming to us. If we can appropriate 8.5 to 12.3 million from the general fund and attract another 20 to 30 million dollars in federal money, I think that will help enormously strengthen the provider network and provide better services for children and adults. So I look forward to voting for this bill. Thank you.
Before we move to Representative Griffin, Senator Baldacci, when you said that this will be an incentive, were you talking, or this would expand the access? Were you talking about including the $1 million incentive or not? Or were you just speaking to the pay rate, the changes in compensation?
Right. I think that if we're adding, I'm not speaking to the $1 million incentive.
Okay.
I'm going on LD 996 in total, because I think it's comprehensive. And in terms of the medically necessary issue, all the bills say in accordance with DHHS rules. So the medically necessary thing is an administrative evaluating tool, more or less. So we're not going to get away from that. We probably shouldn't because of the federal funds. But other than that, I think that expanding it will help strengthen the network.
Thank you. Representative Griffin?
Thank you. I just have a question for Ms. Probert. What age does the coverage stop? So, and when does it? And then my other question would be, if we added preventive care for adults, how much would the fiscal note be?
Sure. So the comprehensive coverage stops at is through age 20. And it is at age 21 that there's lesser coverage. And I can briefly say, just in case it's helpful to the conversation, coverage for adults includes surgical care related to traumatic injury, surgical and medical procedures that don't involve dentition or gingiva. I'm not sure if I'm saying that right. It does include extraction. What I was referring to earlier was treatment necessary to relieve pain, eliminate infection, or prevent imminent tooth loss. So that is a broader category for current coverage. I will stop there. So just to provide a little bit more information on the kind of coverage that is provided to adults, the fiscal for this bill is really the cost of expanding the comprehensive coverage that children currently have to the adult population. So that is what the fiscal that I noted represents. So the 8.5 million with the current rates, and if those rates were to increase per the recommendation of the rate system evaluation, that would go up to the 12.3 million.
Thank you.
Does that answer your questions, Representative? Okay, good. Representative Meyer.
Thank you, Mr. Chair. Just for for some clarity, it's 8.5 million over the biennium, not per year, correct?
That is incorrect. That is an annual number.
And is it a reasonable assumption, as you've seen new coverage roll out, Director Probert, that with the expansion of coverage, the demand would steadily increase and not be there overnight because we have a limitation on resources?
I think that is a safe assumption. I also, so the numbers that I stated are annual numbers. There's also the question of when this bill could be implemented. I made some comments in the testimony to LD 996. There is an ask of the stakeholder group to do a lot of different things, which all sounds very interesting, but is extremely labor intensive, including looking at options for the service delivery system as a whole, including dental managed care. Dental managed care, generally speaking, requires a waiver by the federal government. It requires actuarial determination of rates. There would need to be RFPs for the actuarial work, as well as for the selection of the managed care entity that would be in charge of managed care dental. I say all of this just to note that dental managed care, for example, could very easily be a 2-year process. We could implement a coverage expansion in the absence of managed care in a shorter time period, but it is important, substantial work, both from a systems perspective, from a policy perspective in terms of rulemaking and federal authority, and also, again, if there is a proposal on the rate side, then that's work as well. So there is a lot of work that would need to be done without the addition of very large stakeholder groups and I would say an overwhelming agenda of items that we need to research and report on in a 3-month time period when we're supposed to be doing all the work of implementation as well. So I just wanted to put that out there.
Want to get that in there. Okay. Representative Javner.
Thank you very much, Senator Claxton. Thank you, Director Probert. On that note, when the department is looking at the rate increase, is that coming as a budget line item that we're going to be seeing soon? And what would be the time frame of implementing that rate increase? And then also, as we move forward and we're talking about these numbers being annual numbers, I know I've heard other colleagues reference that we have the money now, but can you explain to us the difference, if there is a difference, even if the department puts in their rate increase as a line item in the budget, what would be the difference in the funding source between this bill, if we just say, yes, we're going to implement this bill, and then what the department wants to do for their rate increase?
So I can say what I said at the beginning, which is that the department right now is working on our proposals to implement recommendations from the rate system evaluation, and that the recommendations from that evaluation included an increase to dental rates. This was the recommendations from the vendor, and so we are determining the department's own plan for implementation of recommendations. The legislature will have budget proposals shortly. I don't know if Molly has any other detail in terms of more precise timing for that, but it is not my decision, so I'm not sure precisely when that information will be shared more broadly. Representative Javner, if you could repeat, I'm not sure I understood your question about the interaction between a potential rate increase with the coverage expansion. Could you repeat that question for me?
Yeah, I'm sorry. It's kind of confusing. I don't even know if there is a difference or not, but I'm curious to note, for the funding purposes from the general fund, if there is a difference between if we pass this bill with the funds coming from just this bill source, and then if the department, when they implement their rate increase, if there's a difference between where the funding is coming from. I'm looking for forward motion here as we move forward, because we have funding right now, perhaps for, you know, the 8.5 million in the general fund every year for this bill, but moving forward, what that looks like. Does that help? I'm sorry.
I think so, but I'm not sure I'm going to have a great answer, but I can say that there's definitely an interaction. So if there were an initiative to increase dental rates, that would absolutely have an impact on an expansion of coverage and increase the fiscal for this as well. And it generally comes out of the same pot of money. I think that that's, so I get that it's confusing and there's different moving parts that impact each other. I think that that's all that I could say on that topic right now.
Okay, thank you.
Did I hear, just for clarity, and I'm not intending to put words in your mouth, but you said soon. Are you talking about the numbers being included in the supplemental budget that's to be considered before the end of session?
Broadly speaking, about the current budgetary process and
Okay.
and the process for that. I think it's being referred to as the Part 2
Yes.
supplemental. Yeah.
Yes. Okay. Thank you. So, Representative Lemelin.
Thank you, Senator. I just wanted to make a comment about, I don't believe that there's going to be a huge influx of people at first, because I'm quite certain, unless things have changed in the last 3 or 4 years, that there's not a lot of dentists that take main care. I remember having to travel. Dr. Mills, Stephen Mills, testified, and I used to have to travel from Augusta down to Scarborough to see him because there was nobody in Augusta. So I just don't see a huge influx at first. I think this is going to be very gradual.
Thank you for that observation. Are there any other questions? So let me speak to some of the topics that have been raised so far this morning. So I hear some interest in being sure that we have legislative authority on report out to create additional legislation. Is the committee comfortable with that concept? That's been fairly standard for interventions we've made before. So I'm looking at heads nodding, and it sounds like there's a relative level of comfort with that one. Okay. I've also heard some conversations about the timeline. It gets a little bit complicated, as Representative Javner has raised, because we can't get several people have raised, we can't get managed care done within a reasonable time frame because that's a big ask and a lot of work, but we could get a program in place. Does anybody have a proposal for a date to get the program in place while the stakeholder group continues to work on it and managed care for later delivery? So I'll go to Director Probert. Is it realistic to think that we could have these rate changes in place by 1/1/22?
The coverage expansion or
The adult expansion.
That would be very tight. We would prefer, with all the moving parts, to be looking at a July 1 would be our preference. And I also just wanted to note that in terms of stakeholder engagement, we have our main care advisory committee. We also have a main care dental advisory committee. So we do have stakeholders who are currently engaged with us on dental care and meet with them regularly. And were this to pass, I am sure Kathy can confirm, she is the chair of our MAC, that we would begin meeting more frequently than we have been. So there is the structure in place to do this kind of engagement already without the creation of a new group.
Okay. All right. So unresolved is the issue of 1/1 versus 7/1/22 for the adult expansion. What about any feedback from the committee on the $1 million incentive? Or is it considered that the expansion to adults is enough of an incentive? Yes, Representative Craven.
Thank you. Is the $1 million a one-time payment or is that ongoing?
I think that would depend upon the stakeholders and their recommendations, but it's really a one-time appropriation to begin with.
I think it's
No?
written as an annual appropriation.
Okay.
Oh, okay.
I think that access is really important, and unless, so I'm really excited and happy that the department is going forward with the rate, with the increased rate, because I think that in order to get dentists to and providers to participate, that we have to be able to pay them. So I think that I would move the $1 million into the, if we're going to be choosing 996, that I would move the $1 million.
Okay. Okay. Senator Moore?
I was just going to mention, thank you, Senator Claxton. I was just going to mention, personally, I am not in support of the $1 million dental incentive program. I feel that if we use that money properly and do the rate increases like we're talking about, that's going to be the incentive in itself, rather than having some plan in place, having to get this working group to identify how we're going to do it, who's going to get it, how are we going to award it. I think we should put our efforts towards, and that's why I've been in support of 996 without the $1 million incentive, and just really work towards making sure we are giving that the rate increase that they really deserve for the work. And then I think we'll see more people willing to take main care. That's my opinion.
And one more clarifying question for Director Probert before I go to Senator Baldacci. If the rate increase that you referenced, if the rate increases that you mentioned are in the special supplemental new one before end of term, whatever we call it, I'm assuming you're talking about the same concerns about delivery date, 1/1 being early and 7/1 being better. Okay.
That is correct. Yes. Thank you.
Okay. All right. Senator Baldacci?
Thank you, Mr. Chairman. I think that 996 already provides April 1st of 2022 as a coverage date. I think that in section 2. So I'm hopeful that we could stick with that April 1st date. I tend to agree with Senator Moore on the $1 million issue. I mean, if we weren't doing anything, if we were doing nothing else and the $1 million was done to improve access, I might have a different point. But I think that what we're doing with 996 is hugely significant, and I'm not sure we need to do the additional $1 million program. At this point, I think it's going forward with this expansion itself is going to be significant. And I think what, and maybe I'm wrong, Representative Javner had mentioned what the impact of the rate study was. I think that the testimony that was provided is that the 996 would cost $8.5 million per year, but if the department does their rate changes, that $8.5 million changes to $12.3 million. But that also ups the federal money. So I think it's a difference of about $4 million. But in either event, I would go with 996. And I agree with Senator Moore about the $1 million addition.
Ms. Del Rio, you have your hand up.
Yeah, I just want to note that in the fiscal note for the previous two bills, Luke included savings from a reduction in emergency department use. So while the cost, I'm sure Director Probert's numbers are correct about the cost, there are likely to be savings included in the fiscal note because there would be a reduction in the use of the emergency department. So that won't necessarily be the final fiscal note, at least it wasn't for the last 2 years.
Yes, Molly.
I apologize. I raised my hand to say exactly what Kathy just noted and forgot to take it down. But that is, this is our estimate for what the cost of the service would be. Obviously, OFPR has a ton of work on their plate, but they add their perspective as well. So This is not the final note that has been passed to you.
And as with the cost, the benefit is going to ramp up slowly too. If we start tomorrow doing dental care on everybody, we don't see the results the next day. It's going to take a while to see that. Okay. So I'm hearing mixed thoughts about, is there anybody else besides Representative Craven who wants to lobby for the $1 million incentive? The reason I would support it would be if it would get money in the hands or get incentive out there for people to expand practice sooner than the rate increase or the expansion of services, then I would support it. But I'm not sure that's the case if we're working through a stakeholder group. So anybody want to advocate for the $1 million incentive besides Representative Craven? I'm not hearing anybody. Yes, Representative Zager.
Thank you, Mr. Chair. I'm sorry, I'm having some technical difficulties and I was just in another committee, so I missed some key discussion, but it does, just in answer to your question, it does occur to me that you know, these rural areas especially are so under incentivized that the $1 million incentive that I've read in the materials does make some sense to me.
Okay. The concern would be that it's tied to the work of a stakeholder group to figure out how to distribute it. And we're talking about rate increases and expansion of services that would be in place by January, April, or July of next year. And so the delivery time wouldn't be all that different. I think that's the argument against.
I see.
Representative Craven, you had your hand up.
Thank you, Mr. Chair. You know, I'm excited just to be moving forward with an adult benefit, and so definitely, especially regarding the rate increase. So I think, you know, and I'm not going to just sit here and not be happy with the dental bill just because of the $1 million. It's just that, you know, we've been seeing this with children as well as adults, that the reimbursement is just not adequate, and that's the barrier that we're having with access.
Thank you for that. The unanswered question that I'm aware of at this point is the number of dental practices or that are out there who are accepting main care. And has anybody been able to come up with a number for that? And I wondered if that was something Molly or Director Probert might have by now. If you don't, that's certainly understandable.
I do have a number of dentists, which is not the same thing as a number of practices. And it also does not include dentists who may be practicing at federally qualified health centers. And we certainly appreciate that FQHCs and RHCs play an important role in dental care. So with all those caveats, the number of dentists enrolled with main care right now is 217.
Okay.
We can work on getting a better number. Kathy, I don't know if you have any numbers offhand, but we can work on that.
Thank you for that. Representative Stover?
I would just add that the 217 is one piece, and then the other is how many each of those 217 can take as patients.
Sure.
Which will vary.
Capacity. Yeah. Okay. So if we go with 996 and leave the timeline as it stands, April 1, that's one option. Does anybody feel obliged to speed that up or push it out further from the committee? Is your hand still up, Representative Stover, or? Yes, okay. All right. So I'm not hearing a change to move it one way or the other, so we could live with 411 the way it is. We could add the legislative authorization for future, and we could recognize that the managed care process is going to take longer. Is that something, Ms. Del Rio, that your group could begin to address if this was recognized as an interest of the committee?
Yeah, I'm sorry. My phone broke up a little bit. Can you just say again what you just
No,
said?
the question is the committee that you're chairing, and I go to you before I go to Director Probert. Could your group take on the conversation about expanding to dental managed care?
Yeah, I think the MAC dental subgroup can take on a lot of the questions that are that didn't exist when we actually drafted the bill. So
Sure.
We could definitely do that. And people who are not members of the MAC can be members of that subgroup as well.
Okay, and so we don't need that language in the bill currently because we have functioning stakeholder groups that are capable of doing that work.
Yes, I'm sure we can work with Director Probert to make that interaction work.
Okay, okay. So that's another piece. All right, so Senator Baldacci, your hand was up?
I was just gonna make a motion of ought to pass as amended with the amendments that you noted
Okay,
on on LD 996.
thank you. Representative Griffin?
After you've thank you. After you've talked this through a little, I'd like to have a corner caucus if I could.
Okay, so before we do that, let's make sure we're talking about the same OTP
Exactly.
as amended. So let's go back to Aaron and what you've captured of the amendments at this point, or any questions you have.
So I'm hearing LD 996 is the vehicle. So section 1 of that bill would stay the same. That's on the coverage expansion. Section 5 on the development of public education materials would stay the same. You haven't discussed that. And the process of engaging stakeholders in the public education campaign would stay the same. Section 6, the report back to the legislature in 5 years to HHS and AFA. You haven't discussed that, so I assume that's the same. Section 2 on the coverage start date and the effective date of the emergency rules adopted by the department would stay as April 1, 2022. You would remove the provision in section 2 relating to consideration of stakeholder group recommendations because you would be removing section 3 that would establish that stakeholder group. And you would keep section 4 that encourages participation of dental providers, just generally.
Okay. Representative Lemelin?
Yes, thank you, Senator. Also, I think we should remove the word children because they're already covered.
In the title, Representative?
Correct. Since they're already covered, to me, it's a moot point. Why?
So is Representative Zager?
Thank you, Mr. Chair. I guess I would wonder if coverage elsewhere were rescinded, and this committee still felt like children ought to have dental coverage through this bill, then I would be in favor of keeping it in there. Doesn't do any harm.
And I think part of the conversation you missed was that kids are already covered in the current circumstance for medically necessary, which is broadly defined for kids. So this bill passing wouldn't change the children's benefit at all or impact it. That was the argument for recognizing that kids are already covered. Senator Moore?
Yeah, just to that point too, I think the other reason why we were keeping child in the title was because when we're looking at the education material, they are, discussing materials and strategies for the distribution of these materials relating to the importance of dental services for children and the availability of comprehensive adult benefit. So I think it's just it's more pneumatics just to have it in there because we are trying to get the word out about it.
Okay.
So I'm okay with the title as it is, personally.
Thank you. So I heard a motion. Has there been a second?
Second.
Okay, so the motion that has been moved and seconded is ought to pass as amended with a number of changes. So I think that's a landing point to take a break. Senator Moore?
I guess I just also want to clarify then, because we will be using 996 as our vehicle and not 62 and 72. Am I correct in understanding that?
I think the plan would be to table those as potential future vehicles, but I would defer to the committee and Aaron for some feedback before we did that. So my intent would be to vote on 996 first, and that would leave us the options to do what we thought was best for the committee on the other two. Okay, so I've heard a request to have a corner caucus. Representative Griffin, would you like to propose a time?
Maybe about 10 minutes.
10 minutes? Okay, so let's get back together at 10:30. Make it 12 minutes. And we'll meet in a caucus to discuss where we are right now. Thank you, and we'll see you in a bit.
mother is terrible.
So it looks like we're back together and back from our respective caucuses. So there's a motion on the floor, ought to pass as amended, with a number of amendments in there. When we left the conversation, there was a question about whether to include children in the title or not. Not sure that that's worth fussing over if the important part's already in the content of the bill. So any thoughts about that? Representative Zager, did you have your hand up? Nope. Okay. So there's a motion on the floor, ought to pass as amended. Any further discussion? So then we'll go to Ms. Withy to run the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 12 yes, 1 absent.
That's a good way to start the morning. Great way to start the morning. All right. So let's move on to consideration of LD 1501.
Senator Claxton, do you want to deal with the other two dental bills before we move on?
I'm sorry, yes. And so I was just so happy about the first go round that I lost control there for a minute. So let me go to Aaron first and say, do we need 2 vehicles, Aaron? At this point, should we be talking about tabling or ought not to pass on these 2?
I don't feel like that's a recommendation that can come from me.
Oh, you don't? Okay. So I do know that there are a number of bills to be considered specifically in the next couple days on Tuesday and Wednesday, later and Wednesday. So why don't we, Senator Moore, you had your hand up?
Yes, thank you, Senator Claxton. I really don't feel, I think there's enough vehicles that we have in place with different concept drafts. So I would make a motion of ought not to pass. We'll start with LD 62.
And I'll
Is
second
there
that.
a second for that? Is there any discussion about that? So, Ms. Withy, can you run the vote? Ought not to pass is the motion on the floor.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 12 yes, 1 absent.
Thank you. Senator Moore.
Thank you, Senator Claxton. I would make the motion of ought not to pass on LD 72.
Second.
Moved and seconded. Is there any discussion about that? So we'll move to a vote. Thank you, Ms. Withy.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 12 yes, 1 absent.
Thank you for that. And before we leave that, I want to thank Director Probert for working with us to help get us some answers along the way. Thank you for that. And Molly, for your contribution, and also Representative Brooks for bringing this forward. And we would thank Representative Fecto, except that he's not here, but I'm sure he's aware. So thank you all for helping move the needle. Now, with Senator Moore's permission, I will proceed to 1501 finally. So let's hear about that from Aaron.
LD 1501 is an act to provide oral health for children in Maine. This bill does a number of things. It changes the legislative goal from ensuring that children on Medicaid receive the same level of services as children on private insurance to ensure that all children in the state with Medicaid receive at least one annual preventative dental visit. It requires the department to expand the preventative oral health services provided in schools through the school oral health program within the Maine CDC. to all schools in the state. And it specifies that the expansion of that program would occur on a rolling basis so that eventually all schools would be served by that program by January 1st, 2025. It requires the department to include in its annual report on dental services to children under main care, a report on the expansion of oral health services provided in schools and how funding has been maximized from other sources, and for oral health staff positions and school-based health services. And it changes the date of that report from February 15th to December 1st of each year. It requires the department to begin a pilot project on value-based payment models for the delivery of oral health services within main care. And the pilot must last no less than 24 months. And there's a report from the department to the HHS committee on the results of the pilot. And finally, it provides for funding for an oral health coordinator in the department to lead the main CDC's public health functions related to oral health. You received some suggested amendments from the Maine Dental Association related to tracking and measuring various data points, annual reporting, developing a postcard mailer on the services provided by the school oral health program and dates of service with a perforated permission slip on it to be distributed to the kids and their parents, and that a dentist should serve as an advisory capacity to the statewide oral health coordinator on an as-needed basis. You've heard this drafting consideration before about giving the committee authority to report out legislation. You had also requested of the department two reports related to dental care, but we do not have either of those reports. And the fiscal impact hasn't yet been determined.
Any response to or questions based on that analysis from the committee? I'm not seeing any. Are folks comfortable with all of the elements of the bill as it's laid out? I'm not seeing it. Yes, Representative Perry.
Oh, I was just going to say that I am comfortable with that we actually have a program that's working very well in Washington County. And to be able to get that to all of the counties and especially the rural areas, I think is very important. So I support this bill.
Yes, Senator Moore.
I agree with Representative Perry, and it's a great program in Washington County. It works really well. The only, I guess, thing I'm not as comfortable with is in the bill where it provides funding for an oral health coordinator in DHHS to lead the public health functions related to oral health. I'm just questioning if that position is really necessary. There's so much that's going on in the department already. I don't think we need to have an additional person just to oversee the oral health, in my opinion.
Okay. Anybody else want to weigh in on that? Join us. Representative Glamour. There you are. Welcome. Did you have a chance to hear the analysis from Erin?
I did, Senator. Thank you. In terms of Senator Moore's concerns relative to the oral health coordinator, as we identified at the public hearing, this program has really been decimated and it's been held together by a shoestring. There has not been anybody at the department to really give this program its due diligence in terms of assuring that all children in schools have these prevention-based programs. So I would really continue to advocate to have that oral health care coordinator position maintained and embedded into the bill.
Thank you. Representative Stover.
I just wanted to also advocate for the position, having been there when there was an oral health coordinator present, and it was a position that not only provided statewide coordination of various programs, but also offered best practices and both information and resources, because someone working internal to the department can also apply for federal grants or seek other resources that will benefit providers in the community who provide those oral health services to children.
Okay. Question for Representative Gramlich. Did you work with the department at all about the July 1 date for the value-based purchasing initiative and whether that's adequate enough time frame?
I did not specifically. We do have some advocates that are also in this meeting that did a lot of behind the scenes work on this particular piece of legislation, and they may be able to weigh in with a little bit more clarity on that. I did want to echo Representative Stover's point about funding. Having the oral health coordinator position also, I think, will enable the state to leverage federal dollars that are very much needed for these kids for their oral health care. But again, I know that there are some advocates. Senator Claxton just done yeoman's work on this particular issue that could maybe do some value add to the conversation in the work session.
And Representative Perry, is your hand still up or another point? Representative Meyer.
Thank you, Mr. Chair. I wonder if Molly would weigh in on the coordinator position.
Sure, thank you. I agree with what's been said about how important that piece is for, in order to be able to do this work, having someone who can do the coordination and make sure that folks have the resources and access to the department that they need to effectively implement these programs would be really, really important.
Thank you. We've also been joined by Becca Matasovich. Welcome. And you're described as somebody who has done lots of background work on this. Might you be helpful to answer the question about a 7-1 date on the value-based purchasing initiative?
Yeah, thank you, Senator Claxton.
Want to introduce yourself first?
Yes, thank you. I'm Becca Matasovich. I lead the Partnership for Children's Oral Health. Thank you all for consideration of this bill. I actually don't know how the 7-1 date was chosen. I think that might have even been by the revisor's office, and I assumed that it was just a logical date because of the state fiscal year and to be prepared for the start of the next school year. I think waiting another year might be challenging because then essentially we're waiting until the following school year. But that's as much as I know about that. And I could also just speak, if it's okay, to the oral health coordinator and the fact that in addition to applying for federal funds and managing those federal funds, which is a really important consideration, there's also the question of sort of whose responsibility it is to monitor access, especially among children who aren't on main care, because certainly main care can do some of that monitoring, but there are half the children in the state who aren't on main care as well. And so from a population-based public health perspective, it's important to have somebody tracking sort of access options, especially given how poor access has gotten over the years. And then there's also some functions, I think, related to workforce development and ensuring that's related to the access question as well, to make sure that we're really developing the providers that are needed. So I think there are quite a few functions that are really important. And currently there used to be 4 positions in the oral health program in Maine CDC, and currently there are none. So just getting one back is really important.
Thank you for that. We've also been joined by Judith Feinstein. Welcome.
Good morning. Thank you. My name's Judy Feinstein. I live in Hollowell, and I appreciate you bringing me into the meeting. This is surprisingly difficult for me to speak to. I held that position for many years, and it's still hard to think about how much was lost, but I'm just going to, and so this is emotional. Sorry, Representative Gramlich, it's more emotional than I thought. There is so much more than that person would do other than the very important work of coordinating a children's oral health program. There are things like water fluoridation. There are things like access. There are certain things about translating science. There are liaisons with other programs in the Maine CDC, in the department, and throughout state government, and partnerships with other states. So and what Becca just said, there used to be 4 people. When I retired from that position, we were down to 2.5, and that was almost 6 years ago. But when I started that job, and this is ancient history, there were 8. So this program over time shrunk. And what I said in my testimony last week was there comes a point where you can't do more with less, you do less. You have an opportunity here to start bringing that position back up so that it's fully functional. And actually, it would address some of the issues that you raised in your last work session, to have that person as a point person. And I'm sorry to be emotional. I was thinking I would be more logical, but that's, I think that's what I have to say. But I would be very happy to answer any questions today, tomorrow, next week. This amazes me how important this is to me even at this date.
Thank you for that. I think you managed to speak logically and emotionally, which is a good way to go. Thank you for being here, and thank you for your earlier work. The 7-1 effort really, in my mind, isn't tied to the school year for value-based purchasing, and there's a rollout provision that gives the department some flexibility. Molly, did you want to speak to the 7-1 date?
Thank you. I'll be honest, I haven't had that conversation with our staff, and so I can't speak directly to it. Although July 1 is certainly soon. And I think perhaps I welcome feedback from Becca or Judy on this, but perhaps aligning it with the school year would be helpful both for implementation timeline and making sure the services are still delivered.
So you're talking now about 9-1, or is that right?
Or 8/15, sometime
Okay.
before the school
Yeah.
year started.
Okay. Do either Ms. Feinstein, do you have a feeling one way or the other?
I don't have a sense of that at all. I would have to either defer to Becca or tell you that we'd work on it and get back to you, which is something I hate to say.
Just want to try and tap your expertise. Representative Limlin.
Not on this one. Yeah.
Okay. Representative Limlin?
Thank you, Senator. I have one question. The bill states that every child would get 1 annual dental visit. Is that correct?
That's what the standard would be. Yes, at least 1.
And
That's the goal.
okay. Who would provide this service?
As I understand it, the answer is the school-based health programs would welcome visiting dental resources. I think that's the model that works in Washington County that's been referred to. So we're not creating new bricks and mortar the way I understand it. Correct me if I'm wrong here, people, but what we're doing is taking a system that's been demonstrably wonderful in Washington County and some other counties and expanding it to availability across the state. Anybody else want to speak to that? Representative Stover? You're still muted. I'm sorry.
There are several counties that have oral health programs operating in schools and school-based health centers, including Lincoln County. Lincoln County Dental goes out to the schools and sees children, non-pandemic, of course, and sees children there. So it's happening around the state, not as fully as we would like, but this is a great beginning to getting towards that goal. Thank you. And it's done through a collaborative partnership of nonprofit oral health providers and school districts. Thank you.
Representative Perry, you had your hand up first, I think, or next.
Yeah, I was just going to add to that, because the way it's done in Washington County, it's a mobile unit. And with a dental hygienist who actually goes to each of the schools. So that's why I say once a year, because there's a lot of schools and it takes around a time to get around. So they're really pretty much out of Washington County working full time to make it to all of the schools, to do the exam at least once a year.
Yes, Representative Gramlich, is your hand still up or did you have
Yeah.
a point to make?
Yes,
Good.
thank you, Senator. Just to really underscore what has been said, I can just share with you, and I know Becca can too, because we used to work together many moons ago with the city of Portland. But when I did work for the city in their public health division, we had a number of school-based health centers within the city of Portland. But at the time, albeit this was probably about 7 or 8 years ago, there were about 25 school-based health centers throughout the state of Maine. And there would be oral health operatories right in those school-based health centers so that kids could get those services. But we also did have those mobile units throughout the state. And the work that these hygienists do with their mobile units, I don't know how the heck they do it, but they're able to get into schools that don't have the school-based centers to continue to provide those services for children.
Ms. Feinstein?
Yeah, the model in Washington County was unusual in that there has been a history of several very cooperative agencies that would house it and facilitate what happened. The same with the city of Portland and school-based health centers that had the ability to put in a dental operatory or host a mobile unit. But these programs were very locally directed. The Aroostook County Action Program has a very wide-ranging, or had a very wide-ranging program throughout most communities in Aroostook County. So there was always an element of some local design, and they would look at local resources. So, and I think that was a strength. So we weren't imposing on a school district or an individual school a model that they really couldn't support, because they participated in figuring out what would work for them. And as dental hygienists became more able to provide a scope of services outside of a private dental office, they could go into schools and provide the preventive services or use mobile equipment. So there's a lot of variation, but the bottom line is the same. The kids get some type of preventive service at a reasonable interval and a connection to the education and referral if they need it.
Thank you for that. Representative Limlin?
Yes, thank you, Senator. I'd like to make a motion not to pass as amended.
Ought to pass as amended?
That is,
Yes.
that's correct, sir.
It's been moved.
And I'll second the motion.
So the motion's been made and seconded. It ought to pass as amended. The amendment being the fiscal note, or is there another amendment that we're talking about? The fiscal note.
Just
Okay. Okay, thank you. Thank you for that. Is there any discussion about the motion on the floor, which is ought to pass as amended, the amendment being the fiscal note? I don't see any, so we can move to a vote. Thank you, Ms. Withy.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 12 yes, 1 absent.
Thank you, Ms. Withy. And thanks to Becca Matasowicz for answering some questions for us and helping with that, and to the bill sponsor for bringing it forward. It fits nicely with some of the other conversations we've had this morning. So thank you for that.
Thank you. You are all off to a great start. I hope the rest of your day goes just as smoothly.
Thanks for being here. And thank you, Ms. Feinstein, for your contribution currently and in the past. All right. So there's no minority report. There's no bills to consider for tabling or ought not to pass. So I think we're all set to go to consideration of LD 1302 and 1424. Aaron?
Okay. So both of these bills in some way change the educational requirements of certain behavioral health professionals. 1302 affects behavioral health professionals operating under Section 65, who are employees of and providing services for children's home and community-based treatment and school-based programs. 1424 affects BHPs operating under both Section 65 and 28 for those professionals providing services for children regardless of the setting in which the service is provided. It proposes amending the educational requirements as outlined in the chart. Both of them are proposing that there'd be a minimum of 60 higher education hours in a related field of social services, human services, health, or education, or a minimum of 90 higher education hours in an unrelated field. LD 1302 adds a requirement to those 90 hours, requiring the program provider to have a specific plan for the supervision and training documented in the employee's personnel file. They both bills also provide that a person with a high school diploma or equivalent could be certified as a BHP among with some other requirements. So under 1424, that includes a requirement that the provider agency have a specific plan for supervision and training documented in the employee's personnel file. And under 1302, it requires that in addition to a high school diploma or equivalent, a person must have a minimum of 3 years direct experience working with children in a behavioral health children's services program, and when the program provider is required to have a specific plan for that supervision and training in the personnel file. Both pieces of legislation provide that any other requirements about BHP training and the time frames for that training prescribed in rule are not affected. Both of the pieces of legislation directs the department to amend or establish contracts to train any number of individuals to become behavioral health professionals within existing resources. And in order to accomplish that training within existing resources, it specifically provides that one option would be to charge individuals or their employers, sorry, that should say employers, not employees, fees for training. LD 1302 is drafted as emergency legislation and provides that these new rules on educational requirements would have an effective date of January 1, 2022. LD 1424 is not drafted as emergency legislation, and it has an effective date of the new educational requirements and rules as of October 1st of this year. You have not yet received a fiscal impact statement. The Department of Education submitted testimony raising a number of concerns with LD 1302 regarding BHPs operating in school-based settings, and has a suggested amendment. I understand that there still might be some concerns with 1424 as drafted, and I know that Erin Fraser from the Department of Education is available to answer committee's questions in that regard. And then I've also just provided a link to similar legislation from last session.
Okay. So does that prompt any questions from the committee to this point? Yes, Representative Meyer.
Thank you, Mr. Chair. Could we bring Erin Fraser and Mallory Shaughnessy in, please?
Done. And we heard from Representative Stearns that he will defer to the wisdom of the community, the committee. So, yes. So were some questions raised in the analysis. Is that something you could help us with, Erin Fraser? Welcome.
Yes, thank you for having me. We also
Do you want to
recognize.
introduce yourself first, please?
Oh, yes, sorry. Very sorry. I'm Erin Fraser. I'm the Director of Special Services, Birth 22 for the Department of Education. And so we oversee all special education programming for individuals birth to 22, and that includes oversight of our special purpose private schools and school-based day treatment programs, where many schools where these BHPs are used. So we definitely recognize the urgency of making sure that we have enough staff, and that in all sections of special education, there is a drought of employees that are wanting to work in the field. So we're working on that as a department. But our concern mainly is because this is a medical certification and the school-based ed tech certification in the Department of Education, the main unified special education regulations, there's 3 levels of ed tech: ed tech 1, ed tech 2, and ed tech 3. And there's a variety of differences in regards to the roles and responsibilities of these ed techs. So an ed tech 1 has really limited responsibility and really can only provide support when in the presence of a teacher. And ed tech 2 has a little bit more autonomy and can do some small group lessons independently under the oversight of a teacher. And then an ed tech 3 would support individual instruction and also community-based intervention, so they can actually take kids out into the community. So there's a little bit of discord in the way that this law is set up and what the actual BHP can function as. So I just wanted to point that out, which would limit the capacity of an ed tech 1, even if it were provided for any kind of school-based service in a day treatment program or in an actual school. And the reason we feel that some of those criteria should continue to be met is because it's not advantageous for individuals who have the least amount of training to work with sometimes the most the most complex and demanding children in our state. So that's kind of a mismatch, and why we really feel strongly that more education and training is preferable when working with our most complex clientele. That being said, we did propose kind of an amendment to that. In the rewrite of 1424, we noticed that there was a plan for supervision and evaluation of these individuals, and it would be important for us that that would be clarified even more, so that the amount of training and supervision would be at the level of, weekly, so that we wouldn't just leave it broad and for other people to determine. Because again, these individuals have the least amount of training, and we want to make sure that they're completely supported if they are going to be working with complex needs for individuals with disabilities. Beyond that, I think I was a BHP trainer. I was trained in the curriculum when it first became available in the state. And so I have a really good understanding of what the training is to become a BHP. And I know that it has shifted slightly, but I also, having trained it for years, understand that it by no means prepare you to walk into a job and be able to support clients. So that even though it is a robust curriculum, it's not the same as getting monitoring, supervision, training on the job as it's occurring. So that just is something that I would put out there. It's not enough to, support someone walking into a job and really understanding how to be effective. So we like this idea of kind of a conditional certification for that level of Ed Tech 1, where you would have a really clear plan on how to increase your training so that you could increase your level of Ed Tech certification, if that makes sense. I would take any questions you have about any of that.
Yeah, Senator Moore.
Thank you, Senator Claxton. Thank you, Aaron, for being here. I guess one of the questions, and I think this is what I'm understanding, that our goal is to be able to get or have more behavioral health professionals available. And by changing the training up, do you feel that that would help, give us the opportunity for more BHPs?
I think it would give you an opportunity for training for more BHPs. I just know that without training and support, it's going to be very complicated. And we see this in currently the adult world, because the adults who are supporting adults with disabilities in supported housing opportunities also only meet that threshold of a high school diploma. And there's a lot, because I'm doing work with extending the age of eligibility in the state, there's a lot of concern about the lack of training those people have to adequately address the needs of adults. So we have that example. And it's just never a good situation if you put someone who has no training with someone with complex needs. So yes, I think it would draw in more, and I think that you could make this more robust by providing a path of training that's pretty intensive.
Great. Follow-up questions, Senator,
please.
If I may. Thank you. In LD 1302, I was noticing where it was requiring a minimum of 3 years direct experience working with the children. Am I understanding that that actually raises the current minimum? That's not required today?
Yes, I believe that does.
Okay.
Yeah, and I do think it would be very hard. I know that there was some feedback from one of the I can't remember who it was, who said that, it'd be very hard to get 3 years experience hired as an Ed Tech 1, because not many people hire an Ed Tech 1 based on their limited capacity and role.
Right. Thank you.
Are there other questions? Not seeing any. Ms. Shaughnessy, can you help us sort out a way forward that makes sense?
Sure, and I appreciate Aaron's comments around that supervision and oversight, and that's why that's in there. Yeah, it's a catch-22. You have to have 3 years experience or multi-years experience, but you can't get them unless you can do it, and you can't do it unless you have them, and it's a mismatch. But the training itself is very robust. I was hoping to get Wendy Enright here today, who is sort of in charge of that training. I think a position you might have had in the past, Aaron. So, what I do know is that they combined the training just like 2 years ago, I believe. There used to be a separate school-based BHP and a separate kind of community-based BHP training. They've combined them into one training, and it is a pretty robust training process that we feel, really ready somebody to do it with some oversight. The only thing, if you have, like right now, you can have 90 credits towards a degree in accounting. And that's got no experience with children, but because you have 90 credits, you can do it. You can get the job. So, somebody with 2 years of, the way we have ours written is somebody with 2 years that is in the field, straight goes in. Somebody with 90 credits, they've had education, they've had training, they've got more maturity. They really don't need the oversight. They currently can come in at that level anyway. Somebody with straight out of high school or with just a high school degree, if we provide that more direct and maybe weekly, supervision, and as well as the BHP training, we really feel that they can be supported and grow right into that job as well. The training itself, the BHP training itself, is really what prepares somebody. It's got a wide array. I think I shared with you the document. Aaron must have it. In my testimony, I shared sort of what that curriculum looks like. I also shared, I don't know if you all had a chance to see it, but I shared sort of the current flow path of how to become a BHP in these different settings, and it is very confusing. There's so many different moving parts to it. And what we're trying to accomplish is say a BHP is a BHP. They've had the BHP training. If you have staff in your office or in your agency, and they're doing home and community work with as a BHP, and they're getting clinical supervision there as well, or they're doing it in a school. Some agencies run both of these pieces, and they could give somebody a full-time job by doing part hours in the school program and part hours in a community evening or weekend program, whereas just somebody in the evening and weekend community program can't necessarily get a full-time job. And that makes it less likely to want to do the job for a lot of people, and it's another barrier. What we're trying to do is just say a BHP is a BHP. We want to reduce the barriers. We want to be able to bring people in, provide oversight, provide supervision, and just say that this is what, like a DSP is just a DSP when you're talking about the IDD world, and a BHP should just be a BHP based on the training that they have, providing a little bit of oversight and more supervision for somebody that may not have quite the maturity to be on their own. And I'd love to maybe say that a way forward would be to say we have, between now and October, we have a stakeholder group that really irons out and defines kind of what that oversight might look like, where we could work together. One of the things that Wendy did share with me too, and I think I shared it with some of you, but if need be, a BHP could simply be a BHP, but in a school setting, in a school-based setting, the school could say, we only hire an ed tech 2 or 3. And so that's separate from the BHP. So they're an ed tech 2 or 3, but they're also had a BHP training. You see what I'm saying? It's a little different than saying the BHP has to have that degree or that background.
We're joined by Representative Salisbury. Welcome. And I'm trying to understand. So is a BHP 1 the same thing as an Ed Tech 1?
There is no like BHP 1. There's
I
just
know,
a
but
BHP.
I'm trying to make them match, but use different terms. You don't want an Ed Tech working in the community.
No.
Right.
We're
So
just
I'm
saying a BHP should be a BHP and they've done the BHP training. If a school district says that we also want you to get qualified as an Ed Tech 2 for this position in a school-based setting, they could do that as well, but then have them do the BHP training like they might do some other kind of training, TCI training, or any other kind of training that they may do as well. So if they feel strongly about it, they could go that route, but a BHP is still a BHP. And in other types of public school-based settings, or with like a special school-based, it could be just a BHP as a BHP.
So you would, I'm struggling with this because I don't live in this world. So you would replace Ed Tech 1 with BHP.
Not really. No, no. BHP
I'm trying
would
to
be
figure
a
out.
certification.
I'm trying to figure out how to do the classification without screwing up a system that's already working. Ed Tech 1, 2, 3.
May I interject something?
Please.
You have to think of a
Please.
BHP as a medical billing code. That's what it is. It's something to bill main care. It has nothing to do with an educational system. That's why you can be, again, previously for Section 65, you could only be an Ed Tech 3. That there was the provision that you could only be an Ed Tech 3 and be a BHP for Section 65. For Section 28, which is home-based services and more functional services, those individuals could have less, they could have less schooling. So it's very confusing, but there are two different mechanisms that work conjointly. So in a school system, many schools don't need a BHP because they don't bill main care. So you only need that certification if you're billing main care. So I hope that clarifies for you.
That does.
Right.
That helps.
So so the school system has their Ed Tech 1, 2, and 3, which does all kinds of different work in all kinds of different settings within the school system. I actually at one point was a Ed Tech 2, I think, along my line. But but the BHP is a separate thing. So a BHP should just be a BHP, and they do the BHP training. if a school system wants to hire an ed tech too and have them do BHP training because
Right.
they want to, be billing, that's a separate thing. Right? Does that make sense, Aaron?
Yeah. I'm getting there. Sorry if I'm slow about all this, folks,
It's okay. It's confusing.
So does 1424 address the BHP issue without screwing up the Ed Tech 1, 2, 3?
Yep.
I see one head nod from somebody who's much more knowledgeable than I. Several head nods. Okay. All right. Okay. So if we went the route of LD 1424, what are the problems with continuing with that bill?
Aaron, would you feel like you'd want to participate and have a stakeholder group to decide what that training or what that sort of supervision looks like? Or do you feel comfortable saying we can just say we're going to hire an ed tech and then they can do the training if that's where you want to go?
Well, I'd be happy to participate in that. I am concerned. I don't think all BHPs are equally trained. I think a BHP with a college, a BA in special education would be much better qualified than someone who just came out of high school. So, and I think that people with more schooling might have more, a better interface with that curriculum, the BHP curriculum. I appreciate that the BHP curriculum has expanded since I only trained on the school-based piece of it. And I used to embellish my trainings. They were very rich trainings, but I still don't think that even if it's a rich training, it might be, how many hours is it, Mallory? 52 hours or 28 hours?
Yeah,
It's
I think it's
52 or
52.
it's between 25, it's between a week to 2 weeks of training. And it just, I do, and again, it's a certification that is in place for billing reasons. I still am very concerned about the level of knowledge that people have when working with very, very complex situations. In a school system, we very rarely hire ed tech ones because of their limited capacity. They can only really support work that's already been taught or monitor people generally in the presence of other supervision. So I don't agree that the individuals would be equal, even if they had that BHP training. We would really love to have kind of the the high school entry level position be a provisional or conditional, so that you had a concrete plan to get that person really the training, the specific targeted training they need to be at full, to be effective at their jobs. And we
Does
know that with training,
1424 interfere with that?
I just don't, it would,
Wait a
it
minute,
would-
one at a time.
everyone
Ms.
would be
Fraser?
able to, go ahead.
No, go ahead, Ms. Fraser.
Oh, I was just going to say everyone would be a BHP. So it does say that there would be training for the high school level equivalent, but it doesn't really do a good job. That it leaves it open to interpretation how much training that would be. And in the adult world, as I'm seeing, there's a lot of under training, which leads to a lot of police involvement and other people interfering with, some behavioral issues that might occur because the training isn't there. So I would love to work on a committee to make sure that we have the training in place. I have a lot of background in this topic. This is like the majority of my work has been with this population of high intense needs. So I would be happy to do that. And again, I support opening this up so that we can get more people in to these roles as well. I just would caution about the lack of training, because I do think that can create health situations. It can create staff injuries, it can create child injuries, all these different things that go through my mind of what we want to prevent in education and in the healthcare community.
Would an amendment to 1424 that says that high school level entry is provisional for 1 year while there is a supervision in place, it would need to be billed at the same rate to help cover the cost of the supervision and everything as well. But if that was put in place, would you feel more comfortable, and could we work as like a stakeholder group till October to kind of fluff out what that provisional would look like?
Yeah, absolutely. I think if you get that provisional with 60 hours of training, you'd get them up to that, and I don't know, I'd feel more comfortable not putting a time frame on it because it might take more than a year, but having them in the provisional certification with the plan to get them to at least the 60 credit hour, to me would feel much better.
And that would work well because most of the agencies that are hiring them anyway have additional CRMA and TIC and just all of these trainings that they have them go through right at the beginning as well for therapeutic crisis and intervention and just all these pieces, which would add up pretty quickly to a more intense training level. So yeah, I think that could work really well, and it wouldn't impinge, like you say, right now on I think it's section 28, it's got the lower criteria, but if they can still hire somebody at that level and they're actually enhancing them, and it's really the work they're doing anyway with them to train them, I don't think that would put a hindrance there. And it just opens up more access and lessens the barriers, which is what we're trying to get to.
Representative Salisbury, do you have any response to this back and forth?
I think it's really a good discussion, and I appreciate the input by Aaron and Mallory. I think the important thing is that we are getting to that need that Mallory just talked about, is the lack of BHPs that are available. And by adding sort of a new category, but adding that training, I feel comfortable with adding that as an amendment, so that we can get those people on board and get them the training that, theoretically, that's what their goal is, to have that training anyway. So they may be working towards that in any event. So that would kind of help that process along. But no, I welcome that amendment and adding that information.
So to the committee, are folks feeling they have enough information at this point? Too much? Wrong kind? Any thoughts? Yes, Senator Moore.
This has been a great conversation, and I am good with what we've been talking about and adding that amendment for the provisional certification. I think that's a great idea. So I would make a motion of ought to pass as amended.
For LD
1424, I'm sorry.
Thank you.
I would second that.
And a second. Representative Craven, you had your hand up.
I did. I'm more comfortable with it because I was a little uncomfortable earlier, but feeling more confident now because I know how very, very complex those jobs are. So thanks.
And in addition to the amendment about provisional, which I think you'll have to work with Aaron on to get the language right, I also heard lobbying argument for a study group to come up with continued work to be done on making community and school-based career paths line up. Is that what I heard?
Or a study group that would help flesh out what that provisional looks like.
Okay.
Really targeted to that, I think, is where we were.
Okay. With the idea that we don't want to screw up any pathways. Okay. That's a advanced legislative term. Okay. Senator Moore.
I guess I get a little concerned, and I understand the need and how we can put this all together. But when we start talking about establishing a stakeholders group, then you've got to define all of that and how do we really want to do that? Or is this something that, Aaron, maybe within the Department of Education that could develop, might be, or what the curriculum might be for this provisional certification?
I think that, again, that would be me trying to impose educational qualifications on a non-educational certification. So I think that it's helpful for me to participate in these conversations because, and also my person who works with state agency clients and special purpose private schools, because it helps just kind of make sure that there's some mechanism in place to support people who might not have training that they need. But I think I don't think it has to be a lengthy work group. I think it just, if we could just nail, just kind of define what this training what it might just take one work group, or we're kind of just defining what we think might be this provisional. And then of course we have to make sure that the provisional BHP is billable. That's another thing we want to make sure that that person is billable, because that's going to be really critical in this work moving forward. But I don't think it would take a significant work study, because I think we have a good understanding of all of the pieces already.
And couldn't that be done in rules as opposed to, but then you got to get multiple departments together. Yes. I've seen a hand up for Representative Perry.
Yes, on this same line, I don't think there's anything that we can't just say that consult with the Department of Education in developing the program.
Okay. Aaron?
Which one?
I'm sorry, Aaron Dooling. Ms. Dooling.
Right. So my question was about, well, it sounds like you might be moving away from the stakeholder group. And my question was around the membership of that group and whether any of the timelines for the effective date of the rule needed to change as a result of that.
I think we're trying to find a workaround the work group. We're trying to figure out some way to get the guidance we need in the hands of the people who are going to use it without necessarily having to constitute a work group and a report back and the risk of additional costs. I saw a hand up. Yes, Representative Salisbury.
Thank you, Mr. Chair. Part of the bill talks about getting some of that training information from the Department of Health and Human Services. So I'm wondering if just the wording being added to the bill saying, requesting that the Department of Education and DHHS work together to formalize what that training looks like. Instead of, like you said, mentioning a stakeholder group or a study group, which could create some work, maybe unintended consequences. I don't know if we can just add that wording into the bill to specify that.
Does that fit with your concerns or address your concerns, Senator Moore, doing it that way?
It does. And I see that Mallory is trying to get your attention and raising her hand.
I'm ignoring Mallory until I hear back from you. Now I'll recognize Mallory.
Sorry, I can't figure out how to raise my hand in any other way, so I'm just kind of waving it here. The thing that I was thinking is too, in the amendment itself could define what that looks like. If we just were able to go and pull in Wendy, who does the training, Aaron from the department, and we could work with Aaron, the other Aaron Dooling. If a few of us just work together, we could kind of probably hammer that out into the amendment and bring it back. I don't think it's too much.
How does that sound to Aaron Dooling? If
the committee directs me to work with stakeholders to do that, I'm available to do that.
We're also kind of protective of our spread thin resources here. So I want to make sure it's doable within a reasonable time frame and with a reasonable effort. This is not a multi-visit effort. Okay. So do we, there's a motion on, yes, Representative Perry.
Sorry, I'm coming back. I just think if we can put something in the bill that says, HHS and the Department of Education will confer on the development of the program, and they can get to their work and do that.
As based on what I'm hearing from various folks, can Aaron Fraser and Mallory, do we think that it's a pathway? A reasonable pathway forward?
I think it could be a reasonable pathway forward. Yep. Just with the parameters that, it would be a provisional, there would be some additional training and oversight or supervision, and that it would be a billable as a BHP.
All of which sound like rules to me and not where I want to go. Okay. Thank you, Representative Perry, for that. So there's a motion on the floor. Ought to pass. The amendment we've heard is to direct the Department of Health and Human Services and the Department of Education to work together to come up with a way to make this more coherent and to set up the provisional status that's being sought.
And this is
that a
on
reason
LD 1424.
on 1424? That's right. Thank you. Is that a reasonable summary, and is that enough for you to work with, Aaron Dooling?
Yes, it is. May I have permission of the committee to run the amendment by both Aaron Fraser and Mallory before we bring it back for amendment review, just to make sure everyone's on the same page?
Oh, I think that'd be fine.
Thank you.
All right. Is there any other discussion of the motion on the floor ought to pass as amended for LD 1424? So Ms. Withy, it's up to you to vote or to get the vote counted.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 12 yes, 1 absent.
Okay. So we want to thank Representative Salisbury for bringing it forward and helping us sort of sort our way through things, as well as Aaron Fraser and Mallory for helping us get this far. So that would bring us to a consideration of LD 1302. I have a hand up, and Representative Meyer.
Yes, thank you, Mr. Chair. I would move LD 1302 ought not to pass.
I second.
Motion's been made and seconded. Is there additional conversation about LD 1302 to be had? Not seeing any. Ms. Withy, you can record that vote.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 12 yes, 1 absent.
And we should note that Representative Stearns brought forth a quite similar bill, and that's helped reinforce our conversation. So thank you all for that. So that gets us to LD 1470. At the conclusion of that conversation, maybe we could have a 10-minute break or a lunch break. We'll be thinking about that. So Aaron, why don't we move to consideration of LD 1470?
Okay. LD 1470 is a resolve regarding reimbursement for providing inpatient care to individuals with acute mental health care needs. The resolve requires the department to amend its rules to provide reimbursement for patients discharged from Southern Maine Healthcare's psychiatric inpatient unit in the amount of $10,166 per distinct discharge. It requires the department to submit this amendment rule to the federal CMS in time for the increased rate of reimbursement to apply beginning January 1, 2021. It directs the department to seek and apply for federal funds and funds from many other sources to pay for the costs of providing psychiatric services to uninsured patients, and to submit a report to this committee on the progress the department has made in developing the reimbursement rate, and the committee would be authorized to report out legislation. There was a similar bill last session, LD 1856, which was not emergency legislation. It was identical to 1470, except that the timing of submitting the amendment rule was 30 days after the effective date of legislation, and the effective date of the new rate was as of the effective date of the legislation. The minority report had a sunset provision was identical, but it had a sunset provision relating to the rate change. A fiscal impact hasn't yet been determined. The department in its testimony asked whether provided some testimony around what uninsured patients might be or what it might mean. And I'm asking whether, given that information, the term uninsured patients is sufficiently clear. I would note that that provision was identical from the legislation that was enacted or proposed to be enacted, but was not enacted, sorry, in the 129th. There's also a timing issue around the retroactivity date. In order to receive federal matching funds, the new rate can only go back to the beginning of the quarter in which the department submits the change to the federal CMS. It doesn't mean the department can't pay rates retroactive to that date, but those would be entirely state funded. So I would be looking for clarification from the committee about what that intent would be to include those services as state funded or not. I've just tried to summarize here what those dates might be if you wanted to only fund them using federal matching funds, depending on whether the bill is drafted as an emergency or not. Currently, it is not drafted as an emergency.
Thank you. Are there any questions that this raises? You brought this forward, Representative Meyer?
I did. Thank you, Mr. Chair. I wonder if you would bring Katie Fulham Harris of Maine Health in, please.
Do you have a specific question of her? Welcome, Katie Harris.
I just think that she can provide us with clarity and any questions.
Okay. So I don't see any questions from the committee about the analysis. Did you hear that, Katie?
I did. Thank you. Yes. And we'd be happy to work on I can just say in terms of the uninsured component, there were discussions with the department now close to 3 years ago related to whether we could include uninsured patients in the rate. And we agreed with the department's analysis that we could not. So we removed them from the rate that we submitted, the $10,166. So the provision related to the uninsured is really just an attempt to have the department seek all means possible at the federal level to ensure that there is potential reimbursement available to cover uninsured patients who use those psychiatric beds.
And in terms of you're talking about federal reimbursement, then that presumes that we're looking for matching money before this money starts to flow?
Yes, that would be separate. Funds to support uninsured patients would be separate. Mm-hmm. So that is not Medicaid. That is not matching funds.
Right.
That would simply be grant funds that may be available. We're just, that's
okay.
That provision.
Leaving that door open. Okay.
Correct.
Questions, thoughts, comments How about the emergency provision and the start date? Any thoughts about that from anybody? Yes, Representative Craven?
Thank you, Mr. Chair. I think that this is certainly a service that is sorely needed in this state, and I agree and support this bill, although personally, I would prefer not to have a retroactive bill for state dollars. I don't know. I would like to make a motion to that effect to ought to pass as amended, changing the date.
Okay. So the amendment would be the date change. Is that right, Representative Craven?
Yes.
Okay.
So just to can I just clarify? So because this isn't an emergency, that would mean the date change would be October 1, 2021. Is that everyone's understanding?
I would say the date should align with whenever we can get a federal match.
And that would be, as I understand it, that's the October 1 date, right, Aaron? Yes, okay. Thank you. People keep moving around on the box when I'm trying to find you to look for the head nods, and I'm looking at the wrong heads. Representative Zager, you had your hand up.
Thank you, Mr. Chair. I was going to second the motion.
Thank you. Senator Moore.
My only question is, are we saying then that this bill would be contingent on federal approval? And if we don't get federal approval, the new rate will not take effect? Is that how I'm understanding it?
I don't think it needs federal.
How is it written currently, Aaron?
My understanding is that we're talking about retroactivity of the rates given the timing of the request was submitted. I don't, maybe someone else has a better answer to this, but I think this is a little different than the bill we talked about earlier that would require a waiver, or the bill we haven't talked about yet. Sorry, that would require a waiver.
That's later this morning.
Yeah, in order to be approved. But maybe Katie Fulham Harris has an answer.
Go ahead, Katie.
Thank you. This does not require a waiver. This would be a straight, this does require rulemaking. So actually, no, I don't think it does. There is an existing, the statute that gets amended currently has two hospitals that have existing rates in it, St. Mary's and Northern Maine Medical Center. So this would just be an addition to that statute. And Molly may have a different perspective, but I do not believe that it would require federal approval.
Yeah, I mean, it's directing a rule change. It's not in statute, but it just talks about submitting that change to the federal government, not submitting, like seeking approval from the federal government.
Molly, does that match with your understanding of where we are in the process?
My understanding is the reason we submit things to the federal government is to get their approval. And if we're spending more funding, that would require more federal funding. We would need approval from them, but that is a broad understanding, and I'd have to check with Maine Care about this specific bill.
But that's not necessarily, that's not at all the same thing as a waiver.
No.
Okay, so the submission to the feds is for approval.
Yes.
Okay. Yes, Representative Perry?
Just so I understand, doesn't require a waiver, but it requires a change in the state plan. Is that what this is about?
Molly?
It requires a rule change, and I believe that means a change in the state plan, but we submit state plan amendment changes almost constantly. But I would need to confirm that with Maine Care, but I believe you're correct.
So if I can read between the lines for Senator Moore's comment, your concern is that this would all hit general funds if there are no federal approval or federal dollars related to it. Is that the concern?
Yes, Senator Claxton, that's what I was concerned about, but it sounds like that may not be an issue.
Okay. So the amendment is the start date of 10/1 for retroactivity. Okay. Any other amendments that you can clarify for us, Aaron?
That's the only one that I heard.
Okay. And so the motion has been made and seconded. Ought to pass the amendment as amended with that one change of the date. Any further discussion? So Ms. Withy, can you run the vote?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 12 yes, 1 absent.
Thank you all very much.
Thank you for helping us wade through all this. Appreciate it, Katie. And we should thank Representative Meyer for bringing it forward again. So thank you for that too. So does anybody want to object to taking a lunch break until 12:30 and then tackling the remaining 5 bills? Speak now or forever hold your peace. So is everybody comfortable then with adjourning until 12:30 and resuming conversations about the remaining 5 bills? I'm seeing some head nods. All those in favor of having lunch till 12:30. Thank you all. We'll see you then.
And under a minimum wage ordinance approved by voters, it would also extend the provision requiring employers to pay 1.5 times the city's.
Another light leisurely lunch. I hope Aaron and Carrie and Molly get lunch every once in a while.
We eat when you eat.
Yeah, but you also have to feed the cat and do a bunch of other things. All right, so we can reconvene for this afternoon's continuation of this morning's agenda and Health and Human Services. We have 5 more bills to consider before we move to a public hearing. And the first of those is LD 843.
Okay, do you want me to share my screen?
If you would.
Okay. LD 843 is an act to create a pathway for housing stability for homeless young people and those at risk of entering and exiting the correction system. It was originally drafted as a concept draft. The sponsor testified at the public hearing that the bill was supposed to do a few things, and then subsequently has submitted a proposed amendment for your consideration at the work session. So I was just going to focus on what my understanding is that the sponsor is currently proposing. It would be a resolve directing the Department of Health and Human Services, Education, and Maine Housing to work together on a plan and protocol for schools to use in order to identify school children and families who are experiencing housing insecurity and homelessness, and the steps schools can take to help school families access available state and federal housing assistance and resources. And the plan would be provided to this committee by next year, February of next year, with recommendations. You would have the ability to report out a bill upon receipt of that plan. And the department would also be tasked with developing a prevention screening tool for housing insecurity and homelessness and provide it to schools, pediatrician offices, hospitals, and clinics, and to use it within the department and DOC systems if a family is at risk of entering either of those systems. Committee requested some additional information relating to the McKinney, sorry about my typos, the McKinney-Vento Act. There's a 1-pager summary that I've attached here, and you also received some funding information from the sponsor that was provided to you. I did reach out to DHHS and Maine State Housing on their position on the proposals and haven't heard back specifically from Maine State Housing, but maybe somebody's available to speak about that. And I know that the department had some feedback relating to this current proposal. And also submitted, I think I submitted this question to Molly, and if I didn't, I'm really sorry. But how much GA funding is used for housing and the fiscal impact, because it's a concept draft, hasn't been determined yet.
Okay, does that raise questions for any members of the committee related to LD 843? Yes, Senator Moore.
Aaron, did we get, thank you, Senator Claus, did we get a copy of the proposed amendment?
The sponsor had, it's copied and pasted directly from what the sponsor had emailed. So it's not like officially drafted or anything, but this is identical to what she had emailed to you earlier.
Okay.
And I understand Carrie's might be trying to reach her. The sponsor had to step away for another appointment.
So can you share your screen again and show us the several pieces of the most recent amendment? So it's now a resolve. So that changes things a little bit. Senator Moore, does that give you a closer look at it at this point with it on the screen?
It does, and I found in my notorious folder here that I had already made a copy of Representative Morales's email, so I see where you pulled that from, Aaron. Thank you. My fault, my mistake.
There's so few pieces of paper to keep track of. Representative Meyer.
Thank you, Mr. Chair. I wonder if Molly Bogart can weigh in on the department's capacity to develop a screening tool.
Sure, thank you. And just since we've taken a break, I'm Molly Bogart, Director of Government Relations for DHHS. And I do think, and this was something that we had shared with the sponsor and with the committee, our significant preference would be to have the department identify a screening tool. I'm sure that these screening tools exist, but our capacity and expertise to develop one is limited. And we would rather defer to experts in the field on this. And so we would certainly, if you were to move forward with this, ask that develop be changed to identify a standardized screening tool.
Any comments, Molly, from you about the concept of bringing DOE and DHHS and I forgot what the third one was, housing, Maine housing together?
Sure, I mean,
process for that.
Sure, I do think that we're grateful for our partners at Maine Housing, and we work very closely with them on these issues, not only for related to youth homelessness, but homelessness and housing across the board. And when youth schools, whether it's school nurses or teachers, social workers, refer families for DHHS services routinely now, and when we need or would benefit from partnership with Maine Housing, we reach out to them, and the reciprocal is true as well.
So this sounds like the work of a work group in some ways. Is that something you all can pull together without a fiscal note?
We really don't have capacity to be doing more work groups without staff to coordinate that work. And so, I would love some more information from the sponsor about what specific gaps she's seeing that are of concern to her before we commit to working to address them, because I think from our perspective, we already receive those referrals from schools, and so I guess the charge of that kind of a working group is unclear to me at the moment.
Okay, Representative Perry.
I'm just looking at this in terms of working with school personnel, and the question about GA is that in the rural areas, we do have a lot of hidden homeless. And I don't know how many referrals that you get from there where they're really homeless, but they're housed. And that sounds crazy, but it does happen. And and at that point, they are involved with DHHS on that part of it. It is, I'm not sure where she sees the problem either. I mean, I've worked with DHHS on children that I've had who have been homeless, and they don't have an option to go to a city, to go to a homeless shelter. We definitely have to work things out with them and how we do this. And there's good coordination with the ones that I've dealt with. So I'm not sure what this is going to do.
And in the language that we saw from the amendment, it's a little confusing in that you're screening for something that's already been appreciated. The way I read the amendment was develop a screening tool to give to people who are struggling with homelessness and housing insecurity. But if you already know that, why do you need a screening tool? A screening tool goes to a general population to identify people that you otherwise wouldn't adopt. So I'm a little concerned that we're going down a road to find something we already know about. Senator Moore.
Yeah, Senator Claxton, those are kind of that's the pathway I was thinking about this bill itself. So as a result of that, I'm going to make the motion ought not to pass on LD 843.
And I'll second that.
Motion's been made and seconded, ought not to pass. Is there discussion about that? Any comments? I don't see any. So we should proceed to a vote. Ms. Withy?
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lumlin.
Yes.
Representative Lumlin. Yes. Representative Stover. Representative Stover is absent. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Sorry. Yes.
Representative Madigan. Yes. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 10 yes, 3 absent.
Thank you. Okay. So that gets us consideration of 3 different naloxone bills, 789, 1177, and 1333. So do we get to see one of those errand charts?
Right. No, actually, I didn't make an errand chart. I
No, I
just am addressing 1333 because at the public hearing on 789 and 1177, the sponsors offered those to you as vehicles.
Okay. So let's talk about 1133 then.
So 1333 is an act concerning the dispensation of naloxone hydrochloride by emergency medical services providers. There are 2 pieces of this bill. The first one is as it's proposed to be amended by the sponsor to replace the bill to authorize emergency medical services persons, ambulance services, and non-transporting emergency medical services to dispense naloxone to an individual who is at risk of experiencing an opioid-related drug overdose, or to the individual's immediate family, friend, or another person in a position to assist the individual. So in the amendment that you received at the public hearing, Section 1 adds the authorization to the section of law covering prescribing, dispensing, and administering naloxone. Section 2 adds the authorization to the section of law governing the licensing of emergency medical services. And Section 3 adds the authorization to the section governing the licensing of ambulance services and non-transporting medical services. A couple of people, including Gordon Smith, and I think some of the emergency services personnel, testified about considering making this legislation an emergency. I have also spoken with the sponsor and Gordon Smith about some technical amendments that would be needed to the amendment as presented to the committee. They're not intended to change the substance, but so one of just to run through them quickly. One of them is that we draft in the singular, not the plural. So you'll see some of those changes. Some of them are to make them consistent with the existing statute about dispensing naloxone. So clarifying that it's an individual of any age, that the person is at risk of experiencing an opioid-related drug overdose. I think there was just a typo. It said standard instead of standing order, and clarifying some of the cross-reference citations. So the second piece of what you had a public hearing on with relation to this bill is a proposed amendment relating to the prescription monitoring program to allow the chief medical officer, medical director, or other administrative prescriber employed by an FQHC or a group practice of prescribers, insofar as that information relates to the prescriptions written by prescribers employed by the FQHC or practice. And it adds this authorization into the section of law governing the prescription monitoring information. My understanding that this is currently available to hospital administrators overseeing the providers within the hospital, and that this would expand them to FQHCs or group practice. You also you received some information from Gordon Smith and the University of Maine system relating to their plans to distribute naloxone throughout the state. And I think that was the only other bit of material that was forwarded to you on these bills since the public hearing.
Any questions come of that presentation on 1333? Yes, Senator Moore.
Yes, I'm just asking, I know that I'm questioning the section that was added about the chief medical officer and the medical director, the K1. Is that very similar to what I had proposed in the veterinarian PMP? That's what I wondered, if it's the same paragraph. Okay.
Yeah.
Yes, but they you decided it should have a public hearing associated with that language, and it was heard in relation to Representative Zager's bill.
Gotcha. Thank you. Thanks for clearing up my head on that.
And just to clarify, Aaron, that access to prescriber behavior in PMP is not limited solely to hospitals, but to
right.
hospital employed providers in groups. So, yeah.
Thank you.
We've been joined by Gordon Smith. Welcome, sir. Any reaction to the analysis? Any suggestions, requests, thoughts you'd like us to have?
No, and good afternoon. Gordon Smith, the Director of Opioid Response. No, I'm thrilled with the work that Aaron has done to tee up these two amendments, and appreciative of Representative Zager's sponsorship of the bill. And they're both important items for us, and I'm just here as a resource. I appreciate the University of Maine putting together the summary of how we distribute naloxone. It's been quite a sophisticated process over a year and a half to put it together with 4 tier 1 distributors and nearly 150 tier 2 distributors, redistributors, so to speak, and we're saving lives every week. There's not much question about that. Along with the Attorney General continuing to supply every quarter the 65 law enforcement agencies in the state. So that data is nicely summarized in that beautiful map and a couple paragraphs that the team has put together for you, which I greatly appreciate.
So you're probably in agreement with the emergency provision, or are adding an emergency provision?
Very important, very, very important. We're still, as many lives as we're saving, we're still losing more than we should. So the sooner that we can have the impact of both these provisions, the better, particularly the allowing the EMTs to distribute and do some education at the scene of an overdose. It's incredibly important.
Senator Moore?
Yes, thank you very much. And Gordon, you're exactly right. We wish we didn't have to have this situation, but it is saving lives. And as a result of that, I think it's very, very important. And I'm going to make the motion ought to pass as amended, adding the emergency preamble to this as well.
I would second that.
So the motion's been made and seconded. Do you need any clarification, Aaron, beyond what we've talked about so far? Okay. So is there any additional discussion? I don't see any. So Ms. Withy, would you collect the vote?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover, Representative Stover is absent. Senator Baldacci, Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you very much. So we'll try and get that through on the floor. Representative Zager.
Thank you, Mr. Chair. I just wanted to thank the committee for the thoughtful hearing and definitely thank Attorney Dooling for her terrific eagle-eyed work in getting things drafted.
Very good. We are very fortunate in lots of ways. Okay. So that would bring us to consideration of LD 789. Yes, Senator Moore.
That's what I was just going to ask if we were going to talk about 789.
I remembered this time.
There you go. So is it because we are thinking about maybe needing this as a vehicle? My thoughts are that we would actually table this bill. Is that correct?
I think that gives us some flexibility
Okay.
that wouldn't be bad to have for the last couple of weeks of intensive committee work.
Just in case we need it.
Anybody think that's not a great idea, or? I don't see any. So is that a yes, Representative Meyer?
Thank you, Mr. Chair. I would agree that we might table and keep one for a vehicle and dispose of the other.
Very good. So do I interpret that as a request to table LD 789, Senator?
With a second.
And a
Yes.
second. So the motion to table has been made and seconded. I think we can do this with a show of hands. Everybody who agrees with the motion to table, please show a hand. That's unanimous of those present. So we'll table 789 and move to consideration of 1177. Representative Meyer.
Yes, I would move that LD 1177 ought not to pass.
Second.
Second that.
There's a second there. Any further discussion? So Ms. Withy, if you could record the vote.
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover, Representative Stover is absent. Senator Baldacci, Senator Baldacci is absent. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven? Yes. Representative Madigan?
Yes.
Representative Madigan? Yes. Representative Javner?
Yes.
Representative Javner? Yes. Senator Moore?
Yes.
Senator Moore? Yes. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 10 yes, 3 absent.
Okay. Moving right along, we'll move to consideration of LD 1487.
All right. LD 1487 is a resolve directing DHHS to seek a waiver for additional medication-assisted treatment for certain persons with substance use disorder up to 30 days prior to their release from incarceration. It directs DHHS by December 1st, 2021 to seek a waiver from federal CMS that would authorize federal Medicaid matching funds for this additional MAT treatment up to 30 days prior to a person's release. The department noted in its testimony that the federal law under the Social Security Act prohibits federal matching funds for the costs of services delivered to inmates of a public institution. I've also included for you current guidance from CMS that addresses that about facilitating successful reentry for individuals transitioning from incarceration to their communities. The Newell Auger provided a copy of Kentucky's 1115 substance use disorder demonstration waiver that's currently pending with regard to their request to do something similar. There is a question that I have, a drafting question, whether the department is required to implement this coverage if a waiver is not granted. I'd recommend clarifying whether you're intending the department to use general fund dollars to cover MAT in this circumstance if the federal waiver with matching funds is not authorized. And I think that's all I have for you.
Any questions, folks? I'm not seeing anything. Molly, do you want to speak to this at all?
Sure, thank you. And Director Probert laid this out in her letter, and I don't think it's a surprise to any of the advocates or folks working on this bill, but the federal government does have a policy that's colloquially referred to as the inmate exclusion, which does not allow us to receive federal matching funds for any healthcare provided to under main care, for any healthcare provided to folks who are incarcerated beyond, I believe it's 24 hours of inpatient care outside of the institution. And so our ability to get federal matching funds through Medicaid for this prior to release will be limited, but that doesn't preclude you from funding this with state funds.
And we don't have an idea of how many people on MAT are discharged per day to figure out what a fiscal note would be.
That would be something probably DOC would need to help
DOC.
with.
Mm-hmm. Mm-hmm. Representative Meyer?
Thank you, Mr. Chair. I was just looking for Representative Stover, who is in the Education Committee presenting a bill. Just looking for her input as the bill sponsor.
Okay. So that's the question on the floor. Senator Moore.
I've asked this question, and I'm not sure if I've asked it actually in our group or if it's been within another caucus. Last session, I know that we passed a bill that was having the Department of Corrections, if they had an inmate that was getting ready to be discharged, like within 30 days, that we would work with them to get them on main care so that the day they walked out the door, they would have main care. If they were, my understanding is if they are having MAT within the prison while they're there, would they not continue to have that once they walked out the door with the main care coverage? And would this be this bill be necessary? I guess that would be the point of my question.
Representative Craven?
I don't have an answer to the question, but I wondered whether all of the prisons and the jails actually do the MAT. I know that Wyndham does because we were there before. But you're right about the main care. I remember that clearly. I understand that that actually is ongoing.
And yes, Representative Perry.
Okay, I'm trying to phrase this in my head. So essentially what this bill is asking for is asking that the state of Maine would cover people who are on MAT in a jail setting, whether it be a county jail or federal jail, that it would be covered for the 30 days before discharge. And so that they would probably come out under Medicaid if they would apply for that. Instead of the jails having to pay for the MAT.
Yes.
That's what we're really looking at.
That's right. And it's really a directive to apply for a waiver.
How do we do that when there is a federal law preventing it?
Well, Kentucky's done it. And that, go ahead.
They've
Erin.
applied. They've applied.
Yeah.
Yeah. It's
They've
pending.
applied. They've done what this bill wants our DHHS to do, which is apply. If the answer is no, we haven't lost anything.
Yeah, can we just ask them to apply? And if the application goes through, we will do it.
Yes, we can do that. Representative Griffin?
I just had thank you. I just had a thought. Can we write a letter asking the department to do that before? There's just a thought.
Yes, Ms. Bogart.
I just want to, Michelle would, our Director Probert would want me to articulate that putting together a waiver application and filing it is a significant amount of work when there is already a lot of work going on in main care. And in regards to a letter, I think it would still cost state dollars. And so without the promise of funding behind it, I think we would be even more reticent to file a waiver application. Thank you.
And the way I read the summary anyway, maybe certainly not with a lawyer's eye, so I defer to Erin on that, but it sounds like it just directs the department to apply for a waiver. It doesn't say anything about funding if the waiver doesn't come through, the way I read it, but I'm not reading it right, Erin?
Well, that's what I would look for clarification on. I think that an assumption might be made in OFPR that the intent of the legislature is that the service is covered by state funds if a waiver isn't granted. And so clarifying exactly what your intent would be in terms of coverage is important. And Molly's correct that this is about federal matching funds, which means that the state is going to have some kind of general fund impact relating to this, even whether it's granted or not. So that couldn't be accomplished in a letter.
Any thoughts? Yes, Representative Craven.
Thank you. I think DOC should be paying for it. You know, I mean, they have their medical budget and their medication budget and all of that, and maybe that this bill should have been, you know, directed at DOC.
So Representative Stover is here. We're having a conversation about your bill and the transition 30-day period and whether folks who are already on MAT would come out already enrolled in main care, and whether that would be adequate and this would be unnecessary.
And I can tell you what I know, or what I think I know, is that prior to being released from jail or prison, your application for main care is submitted at least 30 days, but probably longer. So that with a plan for when you leave the institution, whichever one it is, that you get both your coverage, but also it allows I want to say discharge planners, but they're not discharge planners, but it allows the people the social service and social workers that work inside the jail or prison to make those service connections for you, which would include ongoing treatment. And Molly, if you have anything to the contrary, but that's always been my experience.
As I read go ahead.
That's my understanding as well.
But as I read the bill, it makes no reference to anything other than MAT in 30 days. It doesn't say anything about additional supports or things like that.
This was if I could, Senator, this was specific to Sublocade.
I'm having trouble with your audio.
Well, does that help at all?
Yes.
Great. So this was specific to Sublocade. And I mean, and in real life experience, someone who needs referrals for mental health and or substance abuse usually get those referrals, in addition to having that application provided, submitted for them.
Okay, so do you want to add a provision that they basically get discharge planning services? Is that what you're choosing for?
That would be in the statute under jails and the jails and prisons, I believe, but I'm more than willing to say that it would be part of. I mean, there's no, I don't know if I could require it.
Just trying to get to what you're trying to do. And right now it's pretty specific to MAT. And I think that's based upon how incredibly risky it is at discharge to have somebody who's been maintained to go back out on the street and run into more potent medicine. I understand that rationale. Representative Perry?
I'm still confused with all this discussion. This bill simply says that main care or Maine will cover MAT for 30 days before getting out of prison.
Doesn't say that. The bill says it applies for a waiver, at least the way I'm reading it.
The bill is a request to apply for a waiver.
Yes.
The waiver would make the provision of Sublocade, a particular medication to people which is an injectable, so that it would be on board in someone's system when they leave jail or prison as a homicide, as an overdose death strategy, reduction strategy.
That drug isn't mentioned in the bill that I'm reading.
Well, I can bring it up. I thought it named the drug by its.
As drafted, it just refers to the provision of medication assisted treatment, generally.
On one moment.
So Representative Stover, was it your intent to have the state pick up this cost if the federal waiver didn't come through? Or
Yes, the waiver didn't come, but the request is for the department to apply for the waiver. And in the event that the waiver was denied, I don't know it would be appropriate to put in that if the waiver is denied, then the department will find another way to fund it, or if it, I mean, my intent was to submit for a waiver request.
Okay.
Wasn't intent to, I mean, we could certainly look at that. There are many, so just to clarify, there are many county jails, and I don't know about some of you where you live, but my county jail has a MAP program. It's provided by a private provider, Enos Recovery, that goes into the Two Bridges jail and provides MAT services. However, what they don't provide is Sublocade. And this would be a particular request to use Sublocade as an injectable MAT treatment option.
And that means finding a provider who's willing to continue to prescribe it, right?
It would, although I know that several physician practices that I work with have been are more frequently using it now.
Right.
The prior
And the
authorization
rules,
is
yeah,
easier.
the rules on its use are have been relaxed a lot too.
And the reason being, if you're participating in a MAP program while you're incarcerated, and you've been taking, and you've been taking the strips or pills or whatever your form of treatment has been, by giving Sublocade, it means when you walk out the door, even if you choose not to use your strips or your pills, you already have that on board. You already have buprenorphine on board in your body, which hopefully will reduce your risk of relapse. And that was the intent of this.
And unintended overdose.
Absolutely. Unintended overdose and overdose deaths.
Mhm. So how do we get from what's there to where you want to get to, Representative Stover? Are you proposing an amendment to specifically name Sublocade in addition? And how do you feel about the state owning all or only some of this, depending on what the waiver what happens with the waiver?
I'm open to that suggestion. I would appreciate, I guess, hearing from Molly about that, since it wasn't included in the original. The original is to request.
And unfortunately, Gordon left. He might have some specific information about whether this was even on the radar for grant money.
It's been discussed in the commission. Has Gordon left?
Yes. Molly, do you have any information that might help us?
Well, I can text Gordon to see if he can come back, but also offer my understanding. I think it sounds like what the goal is to allow for injectable longer acting MAT prior to release. And the barrier that we see is that main care cannot cover that, but with federal match. But if, we are certainly willing to keep an eye on how Kentucky's waiver application goes and whether that gets approved, and then also welcome the legislature choosing to provide that service with state funding to eliminate the need for federal approval.
I would be in favor of that.
So you'd like to have this bill written such that the waiver is asked for, and independent of the waiver, there's some cost to the general fund, smaller if there's matching dollars, larger if there's no waiver.
To cover those 30 days for people who are leaving incarceration. Yes.
And are you wanting to make it specific to that particular drug or MAT at all in any form?
The reason for requesting that it be Sublocade was so that it was injected and was on board, because you can choose in the moment to take your oral medication or not. And that's why it was specific to Sublocade.
So this would be a subset of people being discharged who'd agreed to go the route of Sublocade.
Right. And Senator, I think in fairness to the people, I mean, they would have a choice. We can't say that everybody.
Oh,
leaving.
sure. No, that was the point I was making.
I would, so Sublocade would be made available if they would prefer to take an
Yeah.
oral medication. That would still be their choice, but this would be available to them as a choice.
Okay. Molly?
Yeah, I believe Sublocade is a brand, and I'm not sure if there are other options, but if possible to leave it more broad in statute than identifying the brand, I think that would be helpful.
And that's fine. I don't remember the name of it. It was very long. I can certainly look it up. And
So we can put long-acting injectable, yada, 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 yada.
that would be fine.
Okay. Representative Perry.
Yeah, I was actually going to say that because there is another long-acting injectable, which is essentially naltrexone, and that's a 30-day injectable as well. And so if we just put a long-acting or 30-day injectable, because otherwise it sounds like we're going to be doing MAT, which would be like Suboxone or whatever,
right,
through a month. But what you're really talking about is to have a 30-day injectable before they leave, so that would help prevent overdosing.
Yes, yes, Representative Perry, that's exactly it. And I believe that the commission, you serve on the commission, that there's been some discussion at the commission level about injectables.
I don't serve on the commission.
Oh, okay, never mind.
You've just been nominated. Representative Zager?
Thank you, Mr. Chair. Just to add to the comments that are just made, we might also consider not even limiting to injectable. There are certain medications that are implantable, which are long acting, and we don't want to sort of limit ourselves to further delivery methods that could be emerging.
So we can talk about long-acting MAT. Okay. Yes, Representative Jabner?
Thank you very much, Senator Claxton. I can't see the participant list, so I'm not sure, but is there anybody from the Department of Corrections on here at all?
Nope.
No. Okay, so perhaps Molly can answer this question for me. I'm not sure. So how does this all fit in with the Department of Corrections then, and what do they think about having this as an option? Do we know?
I don't know specifically what their thoughts are on this bill. I do know that the Department of Corrections has been working to increase the availability of medication-assisted treatment in their facilities over the last several years. So I think in principle, I can confidently say that they support access to this kind of care, but I don't know what their specific thoughts about this proposal are. I have tried to let folks know as we've been having this conversation, but I know my counterparts are just as stretched as I am, so I'm not sure if we'll get somebody before the end.
Okay, great. I appreciate that. Since it's for the fact that I'm super curious how, I mean, are these, are they already, so they're already patients of MAT then that will have this service available to them? Or is it all of a sudden, someone that's going to be released within 30 days and then they can request this injectable?
It would likely be an inmate that had already stayed for a longer period than 30 days. It would be prior to that last 30 days of your incarceration, because it has to get in your system like any long-lasting injectable, or as Representative Zager described, something that could be implanted. It would already be in your system. So it would be prior to that last 30 days. So you would have already been incarcerated for a longer period of time. And perhaps you had been taken.
Okay, I apologize. I just want to. So someone that's already receiving MAT, or just straight off the bat, 30 days before you can get it?
Somebody who had already been participating in MAT during their incarceration. Otherwise, I mean, not to get into the weeds, but the injectable needs to be in the body for a period of time. If you already have Suboxone in your system, it's going to work that 30 days when you get ready to leave.
And
It's
that's
really-
part of the reason you need the 30 days is for the transition from pills or to stabilize on that dose. They may have been getting it already in jail or incarcerated. But this would change who pays in the last 30 days.
Mhm. Because we know that the most dangerous time for someone is leaving incarceration. We lose a lot of people in that first 30 days as it stands right now.
Yeah. Does that help, Representative Jabner?
It does on one level, but I am still very interested in knowing what the DOC, has to say about it. But okay, so who pays for it right now in the 30 days? Do you know that?
There would be
That would
no,
come out of the DOC budget, wouldn't it?
currently the MAP programs that are provided to jails and prison, again, we need someone from DOC to be able to answer that. I know that the programs exist. And I know that I believe without Gordon here, I think the one that's offered in my jail has some financial participation from OBH, supporting that program to the inmates.
Great, thank you.
Thank you.
Representative Zager?
Thank you, Mr. Chair. The other consideration, besides that, the health ones, is recidivism. People who are suddenly in the throes of a withdrawal are at very high risk of recommitting crimes, and so even just from saving money on the whole criminal justice system is, I think, another reason why this sort of approach makes sense.
But you wouldn't prescribe long-acting MAT to somebody who was MAT naive as they headed out the door, would you?
I'm not sure that you mean it's somebody who had already gone through withdrawal or been under. I would not.
Somebody who'd been sober for a while.
I would not. No.
Yeah, that's pretty risky. Okay. Aaron?
My big picture understanding of funding, and I'm sure someone can correct me on the details, but that if someone's in a county jail, the county is paying for that medical care. And if someone's in a DOC facility, then I think that's state funded. But I'm sure there's details with that, but that's my big picture understanding.
And the only exception that I know of is the programs that are being provided at Wyndham. There's a MAP program at Wyndham that some of us went and toured last year. And there are some county jail programs that are being brought in and provided by substance use providers, not just the medical service they have at the jails. They're actually bringing in qualified substance use programs.
But again, those are local dollars.
Except for, as I said, in the county jail where I live, it's being paid for out of a grant from OBH.
And Representative Dodge has also referred to some grant money that's been used for some of that too. Okay, Representative Perry? Representative Perry, are you frozen?
No, I'm not.
Okay.
I'm warm.
Okay, good.
No, I just wanted to mention that if you're in withdrawal and you're going out, if you've withdrawn from everything, the naltrexone injectable is very helpful in knowing that you can't, whatever you take won't affect you because that takes over. So that is a preventive for relapse once you get out of jail. Also a prevention from death, because these are the people who usually think they can go back to where they were and find out they're overdosing.
Yeah. Okay, so there's still some interest in additional information. Is that what I'm hearing, Representative Jadder?
Thank you, Senator Claxton. Yes, I am very interested in that other information. However, if the committee decides to move forward with a vote, I'm more than willing to go ahead with that as well.
Okay. So what I've heard so far in the conversation, Representative Stover, correct me if I'm wrong, is that you want to name the category of drugs, long-acting injectable MAT therapy, and add that to the bill's intent to generate a waiver application. In
Correct.
addition, if the waiver application doesn't come through, you want the state to be paying for this therapy.
Correct.
Okay. That's what I'm hearing. Yes, Aaron.
Just to clarify, are you looking to specifically identify long-acting MAT as the only type of MAT that the state is applying for a waiver about, or are you specifically identifying that in addition to, I mean, the bill already says that the person should have access to all forms and formulations of MAT. So are you like highlighting this, or are you
Okay.
replacing all the other types?
I think for practicality's sake, I would include that language that already exists and then add including other types of
Including but not limited to.
other long, is it long lasting or
Long acting.
long acting? Thank you. I'm not a doctor. Long acting injectables and other
Bet you
types.
Gordon could help with the language of that because he's done lots of work with the DOC and the jails. So maybe we could get him, Aaron, involved in that crafting that final language.
That's fine. I just am not sure, and I don't mean to be dense or difficult, or but I'm not sure what like specifying that type of MAT adds when it talks about all forms and formulations of medications for SUD approved by the FDA as recommended by the National Society of Addiction Medicine, National Commission on Correctional Health Care.
The reason I had put this in particularly is because it's not currently offered. So you can get Suboxone, you can get strips or pills. I don't think you can get methadone, although I could be corrected on that. But you can get Suboxone in other forms, and some people can't take Suboxone. They would be offered Subutex, I presume. But the injectables and implant, those types of medications have not been offered in jails or prisons.
Well, it does say all formulations as FDA approved. So that's pretty broad net.
And is it because they're not recommended by a National Commission on Correctional Health Care? Do you want to take that part out? Because what if we say it's all forms and formulations approved by the FDA and as recommended by those two groups, including the long-acting MAT, what if those groups don't recommend that long-acting MAT? Does that, I think that it might raise a question about whether those are included or not, because you have this additional qualifier because of the
Perhaps
recommendations.
the qualifier of the groups. Would that work?
Representative Meyer, do you want to jump in here?
I wonder if yes, Mr. Chair, thank you. I wonder if what we need here is DOC present to answer some of our questions.
I believe
and if we might table 1487.
I would appreciate that.
I would second that.
So we'll take that as a motion to table. We'll take that as a second. And I think we can do this with a show of hands. All those in favor of tabling the motion? So that's unanimous of those present. So we'll table this with the goal of getting some more input from the Department of Corrections. One of the problems I see is receiving care from professional. That depends upon whether the professional is comfortable using those tools, those formulations. So we can't tell the professional what to prescribe or what they can or can't use. So it's under professional care to continue therapy at discharge or something like that. Okay. All right, Aaron.
Can I have some clarification on what exactly you'd like DOC to provide to you? Is it just a general assessment of their position on the bill, or is it something more than that?
I think the general assessment, and I'd also like to have them weigh in on the use of those other two forms of MAT that haven't traditionally been provided in jails or prisons. They're newer to the market too. It's in fairness to them.
And I'd ask Gordon what work has been done because he's done extensive work with DOC and the county jails where things stand with some of these availabilities, and he understands prescribing rules. Representative Perry?
I'm still struggling with the intent of this.
Well, technically, I was out of bounds by continuing the conversation because the bill is technically on the table. I was trying to provide a general term, but I think we're getting a little specific. So I think we ought to leave this on the table for now, come back to it. And if you would like to share your request for further clarification with Aaron and a sponsor, that would be a valuable option. Thank you. All right. So that brings us to consideration of a 2 p.m. public hearing. Is there any other business to come before the committee right now? Yes, there is, except, oh yeah, go ahead, Aaron.
We have to deal with LD 129.
We don't have to.
Well, you advertised it, so you have to.
Oh, okay.
You have to do something with it.
Well, yeah, no, I don't have the updated version of the list. It changed a couple times after I printed this out. Okay. So do you want to explain why why there's interest in reconsidering LD 129, Aaron, or?
Well, I wouldn't frame it that way. I would frame it slightly different because reconsidering it is your decision. When I sat down to try to work on the amendment the other day, I realized that by adding a major substantive rule in LD 129, which is drafted as a resolve, poses problems for two reasons. And one of that is because it becomes increasingly difficult to find that authority because it's not in statute. But the second reason is that, as we talked about at the beginning, resolves are for like one-time or short-term duration. So at some point, who knows when, that line is a little fuzzy, but at some point the department ability, the major substantive rule requirement would disappear, and you don't have that kind of sticking around. And so I pointed out that potential issue with using 129 as a vehicle to establish major substantive rulemaking authority. And the chairs directed me to advertise 129 for a work session.
And the thought was that we could reconsider 129. We could make the changes that were necessary to be compliant with the rules and then proceed from there, not really changing the content at all. Do you want to explain that any differently, Representative Meyer?
That is exactly it. I think there was also discussion of adding an emergency preamble to it. So none of the amended language would change. It would become a routine technical rule and with a report back to the committee.
With authority to report out legislation.
Correct.
Okay.
Are there any questions about that? Okay, so at that point, I would entertain a motion to reconsider LD 129. Representative Perry?
I make the motion to reconsider LD 129.
Second.
Moved and seconded. I think we probably ought to record this vote, and so we'll ask Ms. Withy so we can leave good footprints. You're on mute, Carrie.
Rookie mistake. Representative
We're all
Zager.
making them, and some of us aren't rookies.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan. Representative Madigan is absent. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 11 yes, 2 absent.
So LD 129 is now being reconsidered. Aaron, do you want to list the changes that you'd like to see or that you identified as needing to be made to be compliant with the rules, the change from major
Well,
substantive?
I identified the problem. My understanding is the way that you all are choosing to move forward with that information is to keep the rules as routine technical, add a report back from the department upon the adoption of the rules with the authority to report out legislation, and add an emergency preamble.
Any other thoughts, suggestions, requests? So at that point, at this point, I entertain a motion. Yes, Representative Meyer.
Thank you, Mr. Chair. I would move that LD 129 as amended ought to pass.
Second.
And there's a second. Is there any discussion of that? Okay. Carrie, will you want to record the vote?
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan. Representative Madigan is absent. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 11 yes, 2 absent.
Okay. So now we have a 2 o'clock appointment with a public hearing unless there's additional business to be done.
I don't know if Senator Baldacci wants to talk about his vote on 1, 2, 2, 3, the that I emailed you about yesterday evening.
You're talking to me.
So that's fine.
Talking to all of you, yeah. 1, 2, 6, 3, sorry.
That's the bill to set up a separate department of DHHS. What would you like me to say? You want
So
to
your
consider?
vote was ought to pass, and
I
that's
think I
like,
voted, I thought I voted on to pass as amended, but
that's not
Yeah.
what's been recorded. So it doesn't need to be formally reconsidered, but because you're the only one on this amendment, it needs to be stated publicly.
I vote ought to pass as amended, if the amendment being a fiscal note. Does that work for everybody?
That works.
Okay.
Very
Thank you.
good. All right. So now we'll adjourn then till 2 o'clock. And we'll have a couple of public hearing bills to consider. All right. See everybody at 2.
Welcome back to the late afternoon session of the Joint Standing Committee on Health and Human Services. We have 2 public hearings in front of us this afternoon. I think we'll do a quick round of introductions, starting with Representative Zager.
Thank you, Madam Chair. My name is Sam Zager. I represent District 41 in Portland.
And Representative Lemelin.
Good afternoon. I'm Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Senator Baldacci.
Hi, good afternoon. I'm Joe Baldacci. I represent Senate District 9, which is the city of Bangor and the town of Herman. Thank you.
Representative Connor is in his other committee. Representative Craven. Representative Craven. We've lost, there she is.
Hi.
We can hear you, but now we can't hear or see. There you go. You're muted. That's Representative Craven. She represents part of Lewiston.
Thank you, Madam Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescade.
Senator Moore.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Javner, I didn't forget you.
Good afternoon. I'm Representative Kathy Javner. I represent House District 141, which is located in Penobscot in Washington County.
Representative Perry.
Good afternoon. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Senator Claxton.
Hi, I'm Ned Claxton. Welcome. I represent Senate District 20, which consists of Auburn, where I live, mine at Mechanic Falls, Poland, and New Gloucester.
And I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott, where I live, and parts of Kittery and South Berwick. For those testifying this afternoon, we would ask that in order to help our clerk, Carrie Withy, manage the attendee list, that you exit the webinar once you've finished your testimony and answer any questions from the committee and watch the rest of the hearing live on YouTube. We take testimony in the following order: sponsor, any co-sponsors, and other legislators, those providing testimony in favor of the bill, those opposing the bill, and then finally, those neither for nor against, but with additional information for the committee. We run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left, asking you to kindly bring your testimony to a close. Public hearings are just that, for the public. The process of hearing testimony certainly encourages probing questions, and the committee uses the raise hand function in order to ask those bill-related questions. We also have our analyst, Erin, with us this afternoon.
Hi, my name is Erin Dooling. I'm one of the legislative analysts for the Health and Human Services Committee.
And our able clerk.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
So we will hear LD 745 first. Do we have Representative Millette in the building? Yes, she is here. Welcome. Representative Millet.
Good afternoon. I think I'm now fully here. Excellent.
You are. Welcome.
Okay. Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of the Committee on Health and Human Services. I am Rebecca Millett, and I represent House District 30, which is most of Cape Elizabeth. I am pleased to present LD 745, an act to strengthen Maine's public health by expanding access to certain health programs and services. In 2009, Maine passed legislation that authorized the universal purchase of vaccines for Maine children through the establishment of the Maine Vaccine Board, or MVB. The board oversees the Maine Universal Childhood Immunization Program and created a process by which the state of Maine purchases all childhood vaccines for children who are not eligible for the Vaccines for Children, or VFC program, and distributes them to providers free of charge. So providers no longer need to buy private vaccines and potentially face being reimbursed less than actual cost. The assessment for vaccines are paid by the health insurer, so the provider no longer needs to finance vaccine inventory. The cost of vaccines procured by the state's Department of Health through the CDC VFC contract are significantly lower than privately procured vaccines. Hence, insurers and other payers ultimately pay less for needed vaccines. And when insurers pay less, Maine businesses and families pay less. Most recently, the savings for the program were estimated at roughly 30% for 2019 and 2020, which was nearly $6 million in 2020. I've included in my testimony the most recent report. Alaska, Rhode Island, and Vermont have successfully implemented a fully universal purchasing program, including children and adults. As you would imagine, adult vaccine programs are more narrow in scope. Alaska's estimated savings for the adult program were roughly 45% for 2017-2018, which was the most recently available data. The bill before you would have Maine create a fully universal program as well by amending 22 MRSA 1066 to include adult lives and extend the savings for those vaccines. Currently, purchases for uninsured children are funded through the Federal Vaccine for Children program, and purchases for uninsured adults can be funded through the federal Section 317 grant program. We all benefit, including providers and insurers, from uninsured Mainers having access to vaccinations to limit the spread of communicable diseases. I believe there may be additional administrative expenses resulting from the expansion, which is why the bill creates a new fee included in the assessment, which is capped at 5%. It can be anything less than and up to 5%. The Maine Vaccine Board has overseen the Children Universal Vaccine Program since its inception and has created great savings for providers, insurers, and Mainers. The board decides which vaccines to include the program and the required assessments. The board has the experience and is well equipped to oversee the expansion of the program to include all Mainers. Additionally, the insurers have representation on the board and have a role in making sure the program is effectively implemented. At the end of my proposed language is an effective date of September 2022 in order to give the Maine Vaccine Board and the Department of Health and Human Services time to work with the payers and providers in making necessary changes, as well as apply for and receive additional funding from the federal Section 317 grant program. I hope we all can agree that it's good public policy to reduce healthcare costs and financial burden on our employers and citizens. That's what this bill does. I hope that you will join me in supporting LD 745.
Thank you, Representative Millet. Questions from the committee for the bill's sponsor? I am seeing none. We will move to testimony in opposition to the bill and welcome Catherine Pelletreau.
Yes.
Welcome.
Thank you. Representative Meyer, Senator Claxton, members of the committee. My name is Catherine Pelletreau. I'm the executive director of the Maine Association of Health Plans. We have 5 members. It's Anthem, Blue Cross and Blue Shield, Cigna, Aetna CVS Health, Community Health Options, and Harvard Pilgrim Healthcare. I also serve as a member of the Maine Vaccine Board and have since its inception. So I was one of the people who was involved with, at the time, Representative Connor, who pulled together a group of stakeholders to develop the details around a proposal that successfully made it through the legislative process, is now law, and has been operating very well for over 10 years now. Representative Millett is absolutely correct. There's substantial savings for many parties associated with the Universal Access to Childhood Vaccines Program. But I'm here today to testify in opposition to this version of the expansion. And the reason is really twofold. The first is carriers and employers should not be paying for the uninsured. We are willing to pay for our own members, and that's the way the childhood program is structured. There's an assessment methodology that charges, kind of a per head rate per member per month. And in the childhood vaccine program, it's on child lives. And presumably in the adult program, it would be on adult lives. Remember also that this assessment applies not just to private health insurance companies, but also to the self-insureds. So for any employer that is hiring a health insurer as a third-party administrator, but bears the own risk for their insurance program, they also fall under this assessment. And if you're not going to hear from them today in the public hearing, I can pretty much guarantee you that they also will object quite strongly to being asked to pay for the uninsured. So really our opposition lies in that primarily, and also the number of questions related to a proposal like this that have yet to be worked through. So we're very supportive of Representative Millett's suggestion that this go to the Maine Vaccine Board. As she said, it's a multi-stakeholder board. It's very familiar with the financing and what has worked well for the childhood program. And I think it's an excellent place to have an analysis of a potential expansion to adults happen, and the opportunity to walk through some of the questions that I've outlined in my testimony for you.
30 seconds.
Yeah, I think I'll stop there. You have written testimony from me, so you can see the detailed questions about the proposal as well as the policy matters we think need more analysis. I'm happy to take any questions.
Questions from the committee? Yes, Representative Craven.
Thank you, Madam Chair. Do you pay for uninsured children?
No, we don't. The VFC program pays for uninsured children, so the vaccine-free children or childhood pays for uninsured children. And in fact, one of the pieces in the law that was carefully negotiated is a prohibition on assessments from the private sector paying for public kids and public dollars going to pay for the private kids. So there's a designation in the law that very carefully marks out that private should pay private and public should pay public.
Seeing no other hands up, we will hear from Peter Gore, testifying neither for nor against. I'm not seeing him here. Kerry, is he? I see that he's in the, here he is. Welcome, Mr. Gore.
Thank you, Representative. I had to come through the wormhole for a minute.
Yep.
The committee is.
We've heard it's an odd experience. Welcome.
It is. Good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Peter Gore. It's a pleasure to be here. This is not a committee I usually appear before, so it's nice to have a different experience for a change. I am the Executive Vice President at the Maine State Chamber of Commerce, but under the Full Disclosure Act, I am also the chair of the Maine Vaccine Board, and I have been for the past 10 years. And I was involved with the group of stakeholders that got together 10 years ago that put the Maine Vaccine Board and the Universal Children's Vaccine Program together, that has operated so well over these past 10 years. I'm in a somewhat of a disadvantage because I do not have the language of the bill. It was not shared with me, and the sponsor did not confer with us prior to going forward with this. So I don't know exactly what the language is. So my testimony is a little off base. And in all honesty, had I brought this to my policy committee, had time to do it, I only learned about this bill Friday afternoon, I would have a position for you, but we're not meeting until tomorrow, so I can't do that. I want to echo a lot of the comments that Ms. Pelletreau just made, and it is the reason we are here. We do not believe that we should be paying for uninsured individuals. And we also want to make sure that if you decide to go forward with this, that it's a workable program. I think it's important to remember that the fundamental underpinning of the vaccine board and the program was the pooling of resources from the various payors, insurers, which is really employers and individuals, and self-insured individuals. That the money then goes to the Maine CDC and they're able to purchase the vaccine at a reduced rate. That's what's resulted in the savings, and that's what's enabled us to give the vaccine to physicians in the state and have it distributed. I think the question is that possible for adults? I know the representative indicated that in other states it has. I think more detail needs to be fleshed out. I'm not here speaking to the vaccine board, and I don't want to pretend to. I'm speaking solely for our members and the business community around this issue. But the vaccine board has not had a chance to review this legislation and has not taken a position on it. I don't think this would have ever happened 10 years ago had Representative Connor, who did submit testimony on this bill, not taken a collaborative, cooperative, stakeholder approach to trying to make this happen. And it's part of the reason the program, I think, has worked so well. It's been so successful. And I'll be honest, I've been doing this for 30 years. Believe it or not, when I first started in the lobby world, I had Molly Bogart's position at the Maine Department of Human Services back then. I am prouder on a personal level of my work with the vaccine board and what we've been able to accomplish than there are only very few things that I'm more proud of than that. Whether this program can work or not, I can't tell you. I think, however, that if you decide to do it, it should be in the same spirit that Representative Connor went forward 10 years ago. And that means either getting it to the Maine Vaccine Board for a review to see if it's possible, or to put together a stakeholder group, much like the one was established 10 years ago, to see if it's a doable thing. With that, I'll stop my testimony, and I'd be glad to answer any questions that you have.
Thank you for your testimony. Any questions for Peter Gore? Seeing none, appreciate you being here today.
Did my job. Thank you. Have a great afternoon, everybody.
You too. No one else has signed up for testimony on this bill. So I would ask the committee if you've got any questions or requests for information from Aaron Dooling. Seeing no hands up, I'll close the hearing. And on LD 745, an open hearing on LD 1601, Resolve to establish an advisory panel to study the implications of genome editing technology for the citizens of the state, and welcome the bill's sponsor, our esteemed colleague, Representative Zager.
Thank you so much, Madam Chair. I know this has been a very long day, and so I appreciate the committee's attention to this matter. Senator Claxton and Representative Meyer and esteemed colleagues on HHS. For the record, I am Sam Zager, honored to represent District 41 in Portland. Presenting this resolve to create a temporary advisory panel to study the implications of gene editing technology in Maine. With all of the important bills the 130th is considering, with all the weighty things in the news, it is very easy to miss the fact that we are witnessing a technological advance for the ages. CRISPR-Cas9 is a molecular tool that enables someone to edit genetic material like we all edit documents using our word processors. It's being used every day in Maine and around the world, and today you'll hear from scientists who are doing so. Humans now have direct, precise, accurate, and inexpensive non-breeding control over which genes are passed, and therefore which traits are passed from one generation to another in any species. For the first time since life began on Earth, this power is in mortal hands. Alarmed by the prospects this means, the international scientific community put a halt to human gene editing in the cells that would be passed on to the next generation, the so-called germline. I'll mention that there's a video. Somebody who couldn't testify today prepared a video. He's the chair of the National Academy of Science Committee on Emerging Science, Technology, and Innovation. In other words, one of our nation's leading scholars and scientists and policymakers on this. Dr. George Daly. He prepared a video about the international scientific community's response to this, which is linked at the bottom of my testimony for members of the public to view if they would like. And I've shared that with the committee. So this still leaves a lot of possibilities in so-called somatic or non-heritable human cells and all cells in other species. For instance, we can eradicate deadly and cruel single-cell diseases like cystic fibrosis, sickle cell anemia, and hemophilia. It also holds promise for addressing multifactorial diseases such as cancer, heart disease, various kinds of mental illness, and HIV infection. The preamble of LD 1601 elaborates on many of the implications of this technology. I won't read it to you, but I draw your attention to it, looking at the health, environment, economic viability, and national security concerns that are raised. Likewise, there are significant ethical considerations, for humanity has stumbled occasionally when deciding what traits, and therefore who has those traits, are worthy. I'm not saying that it's up to Maine to figure this out for humanity. This resolve simply tries to frame the issue and point out that Maine has an opportunity to be a leader. We can begin to have this broad public discussion that the scientific community has been having and is asking non-scientists to join. LD 1601 proposes to do just that. With this resolve, the legislature would convene a temporary panel for a little more than a year. The panel would study the implications of gene editing technology and the legislative, administrative, appropriations, or other steps that the state should take to capitalize on the tremendous potential and avoid the hazards of this technology. The panel would submit a report by the end of 2022, including its findings and recommendations, including any suggested legislation for the 131st legislature. There's a lot of human suffering caused by disease that we can help alleviate in Maine. I will leave it to others who will be providing testimony to go into the details on that. But I would also submit that we as a state can't afford not to have a plan. We do not want to be penny wise and pound foolish. Consider this. Every 2 years, the Millikan Institute publishes rankings in its state technology and science index, an objective grade of each state's capacity for achieving prosperity through scientific discovery and tech innovation. I'm very sorry to share that we are ranked 43rd in the country, and we have fallen 5 spots in recent years. The National Science Foundation published findings of states' investment in research and development and similarly found Maine lacking. Over the course of 16 years, the median US investment in R&D increased by 38%, but Maine only increased by 8%. I'm not saying we're going to reach or compete with California and Massachusetts in this regard, but consider that North Dakota increased by 153% in the same period, and Wyoming increased by 243%, while we were 8%. If we don't jump deeper into the science and tech economy soon, we will be selling our future short. Researchers in Maine are doing incredible work, and you'll hear from some of the terrific ones today. But the legislature could do more to help, and genomic science presents a fantastic opportunity. We can chart a course to educate generations of Mainers in math, science, and engineering, to attract public and private capital to Maine institutions like the University of Maine system, private colleges as well as the Jackson Labs, MDI Biolab, Bigelow Labs, and the Rue Institute, and others, all here in Maine. We can be at the forefront of blending scientific inquiry and bioethics, benefiting our state and humanity at large. The scientific community literally is asking for conversations in jurisdictions outside of itself. We can nurture a thoughtful conversation about how we can do the most for Maine and the people who live here and will live here. We can be proactive. Tech-rich Washington state is the only other state legislature that I know of that is as far along as Maine is on this. Imagine if in 1970, somebody in the Maine legislature said, you know, computers are going to be really big. They will affect just about everything in our society. So let's think about how Maine can be a leader in that. Would the world know the Kennebec Valley today like they know Silicon Valley? That's the sort of moment we are in regarding gene editing. This resolve does not take a position on any particular course of action regarding the issues raised by gene editing technology. It merely suggests a way to develop a plan for the benefit and the future of Maine. If anything in this hearing strikes a chord with you or your constituents, that's the point. It underscores the importance of convening the panel, because these things are happening with or without us. So we can choose to be thoughtful about it and jump in so that we can ride this wave. Thank you very much for your time and consideration. I really appreciate it and be happy to answer any questions.
Thank you, Representative Zager. Representative Griffin.
I don't have a question, Representative Zager, but I need to make a comment. I understand as a doctor, this science can be very exciting, but as a Bible-believing Christian, I find your statement, for the first time since life began on earth, this power is in mortal hands. And I just needed to make that comment. Thank you.
Seeing no other hands up, we will hear from Representative Patty Hymanson. Welcome, Representative.
Thank you. Thank you, Representative Zager, for introducing this bill. Good day, Senator Claxton, Representative Meyer, members of the Joint Committee on Health and Human Services. I'm Representative Patty Hymanson, representing House District 4, parts of York, Wells, Sanford, and all of Ogunquit. I'm speaking in support of LD 1601, resolved to establish an advisory panel to study the implications of genome editing technology for the citizens of the state. Any living thing with DNA can have its genes changed with this technique. CRISPR, clustered regularly interspaced short palindromic repeats. You can buy right now on the internet a home kit from Odin for $40 to insert glow-in-the-dark jellyfish genes into bacteria using CRISPR. It is an easy and inexpensive technique that uses a molecule that cuts the DNA dragged to the right spot by a scouting template. In fact, Jackson Lab in Bar Harbor grows a mouse line that has the cutting molecule already in each cell in the mouse. So only the scouting template has to be used by the lab that buys the mouse. We now have ants that can't smell, coffee beans with no caffeine, mice that don't get fat, and salmon that don't lay eggs as examples. This is a technique that will be used in ways we can barely conceive, and there are deep ethical concerns attached to it. Maine can position itself to, quote, capitalize on the potential and avoid the hazards of genome editing technology, quoted from the bill. We can start with enabling the advisory panel and its work described in LD 1601. There are diverse ways that CRISPR touches and can touch Maine. Jackson Lab and East Boothbay's Bigelow Lab for Ocean Sciences are two. The University of Maine and the Extension Program, working with crop health and insect populations in the face of climate change, might be others. The glow-in-the-dark gene can currently be inserted in chickens to sex chicks in the eggs, as an example. Invasive fish species, plant species, tick-borne diseases, crops of oysters whose shells could be hardier in our warming Gulf of Maine could all be approached with CRISPR. The advisory panel established by this resolve could be the first step in a statewide dialogue to capitalize on the potential and avoid the hazards of genome editing technology. And there are hazards. And that's part of this advisory group's mission, is to look at the hazards, the ethical hazards as well. I approach this technology with excitement and deep caution. And both of these reasons are ones that would benefit from the passage of LD 1601 to get the conversation started. I'm happy to answer questions, and I look forward to your discussions.
Questions for Representative Hymanson? Seeing no hands up. Nice to see you here today.
Nice to see you all. Thank you.
Asha Sidhu, welcome. We're having a hard time hearing you. It looks like you're off mute, but we can't hear you.
Can you hear me now?
We can. Thank you.
Senator Claxton, Representative Mayer, and other honorable members of the Health and Human Services Committee. My name is Asha Vermani Sidhu, and I'm currently a senior at Colby College in Waterville, Maine. Today, I'm testifying in support of LD 1601 because although I was unsure of my opinion on gene editing when I first started college, through research, genetics classes, and lab meetings, I have learned how gene editing can be extremely beneficial to human health. In my genetics class here at Colby College, one of our final assignments was to debate whether or not it would be ethical to use CRISPR techniques in human beings. My team's argument was based on the fact that there are numerous ways in which CRISPR can be utilized in order to improve human health. Directly through embryonic gene edits, to decrease or eliminate the effect of detrimental genetic diseases, and indirectly through CRISPR and other organisms to improve healthcare platforms which already exist. So this is the research that I conduct. In the fall of last year, I worked alongside Dr. Jose Fernandez Robledo and a small team on a molecular project where the goal was to see if we could use CRISPR techniques in a marine protozoan parasite, Perkinsus marinus. Perkinsus is a single-celled organism which is found here in Maine and actually is the cause of dermo disease in oysters. Perkinsus is filtered by a mollusk host and it infects their blood cells before proliferating and eventually killing their hosts. Here in the Gulf of Maine, we have observed major breakouts of dermo disease in the warmer summer months, although it is still prevalent throughout the rest of the year. I use this organism as a good example for advocating for CRISPR and other organisms to improve human health because, as seen in a study with humanized mice, Perkinsus can act as a natural adjuvant. So this means that it can kickstart an individual's immune system and makes it a great subject to use when developing vaccines. This direct health application is one of numerous ways that CRISPR can be used to benefit our society. I personally feel extremely lucky to have worked with such a cutting-edge biotechnology technique as an undergrad in college. My experiences with CRISPR have inspired me to continue working in biotechnology and hopefully attend graduate school after I graduate. Thank you for your consideration, and I'm happy to answer any questions or elaborate on anything else.
Questions from the committee? Seeing none, thank you for being here today. We will welcome Barry Larman. Mr. Larman? Would you like to unmute
Okay,
yourself?
Can you hear me?
We can hear you, yes, sir.
Okay. Senator Claxton, Representative Meyer, other members of the committee. Oh, hang on, let me start my video. Okay. My name is Barry Larman. I live in Portland, and I'm here to speak in favor of LD 1601. While I hold a PhD in biochemistry and molecular biology, I'm not here today to speak as an expert. I've been retired for a decade and I'm speaking solely as an interested citizen who's been following developments in gene editing over the last several years. I wanted to begin just by referring briefly to 3 significant developments in genome editing that have occurred in the last few months alone. First, about a month ago, the trial of a new gene therapy for sickle cell disease was approved by the Food and Drug Administration. This is the first CRISPR-based trial to be approved in the United States, and it's likely that that technology will prove groundbreaking in medical therapies. Second, only a few days ago, the first of millions of genetically engineered mosquitoes were released in the Florida Keys with the goal of substantially eliminating the species of mosquito that is responsible for spreading dengue fever and the Zika virus. This version of the transgenic mosquito that was used in this was developed almost 2 decades ago, and it's the first genetically modified mosquito to be released in the United States. Third, the Food and Drug Administration has recently approved for human consumption Atlantic salmon that has been genetically engineered to grow almost twice as fast as its wild type cousins. This salmon was first engineered almost 30 years ago, but it is the first genetically modified animal to be approved for human consumption in the United States. The genetic modification of living things using recombinant DNA technology like CRISPR has been going on for a long time, and the pipeline of genetically modified organisms and therapies is extensive. These groundbreaking products will be appearing at an increasingly rapid rate, especially now that scientists are harnessing the incredible genome editing power of CRISPR. I believe there is great wisdom behind what LD 1601 seeks to accomplish.
30 seconds, please.
We must prepare ourselves so that we may adopt the best policies regarding the increasingly rapid development of these genetic manipulations. We will be confronted with truly profound applications regarding these technologies. We will be confronted with incredible ethical issues, and all this will come at us with an increasing velocity. I'd be happy to answer any questions.
Yes, Representative Craven.
Thank you, Madam Chair. Thank you for your presentation. So, for example, if somebody's born with CP, do they have to have the splicing when they're babies, or can they have that when they're an adult? And then also, is this like a big operation, or I mean, how is it installed? How are the, you know?
I'm really not an expert in that field, so I can't tell you. I think these therapies with CRISPR can be used on adults. I don't think it has to be done on a child. Probably more healthy for the child the earlier that it's done. The sickle cell initial experiments were done with a youngster. From the look of him, I guess he was 12 or 13.
I did see the pink and green and blue mice at Jackson Lab. They were really cool.
Representative Zager, is your hand up?
Oh, yes, Madam Chair. I just wanted to mention that I saw some of the testimony that's been submitted. We'll address some of the questions that Representative Craven brought up regarding adult use in adults and for adult conditions.
Thank you. We'll hear next from Benjamin King. Welcome.
Good afternoon, Senator Claxton, Representative Mayer, and other honorable members of the Health and Human Services Committee. My name is Benjamin King, and I am an assistant professor of bioinformatics at the University of Maine. I am testifying on behalf of the University of Maine in support of LD 1601. We should all take pride that Maine is the national leader in biomedical research. For example, UMaine recently created the Institute of Medicine. As part of the Institute, I lead a genetics study of chronic kidney disease in collaboration with Northern Light Eastern Maine Medical Center. The university is also part of the Maine INBRE program that seeks to increase Maine's biomedical research capacity and is led by MDI Biological Laboratory. Over the past decade, over $68 million in funding from the National Institutes of Health has been awarded to its network of 14 Maine institutions. Maine is also a national leader in bioinformatics. These methods are required to analyze and interpret increasingly large biological data sets, such as whole genome sequence data from our kidney study. Through Maine INBRE, we've also trained hundreds of researchers from Maine and beyond. Numerous bioinformatics resources on the biology of the laboratory mouse developed at the Jackson Laboratory are used by researchers across the globe. In a new collaboration with Northeastern University, we're developing an artificial intelligence-based method to study the immune response to influenza virus infection. We also have expertise in using genome editing technologies that have accelerated the development of animal models of human disease. For example, my research laboratory uses zebrafish to study how the immune system responds to influenza virus infection following protocols that have been approved by our Institutional Animal Care and Use Committee. Both the zebrafish and the virus have been genetically engineered to express fluorescent proteins that allow us to visualize the response in real time. Biomedical researchers like me rely on these animal models to study disease mechanisms. Without the knowledge gained by these studies, we would not be able to develop new diagnostic tools or therapies. The ethical, legal, and social implications of genome editing are complex and interdisciplinary. Strategic public and private investments in biomedical research and education, including in ethical, legal, and social implications, would further reinforce Maine's leadership role in genetics and biomedical research. The advisory panel proposed would elevate what is already happening in Maine and better position the state to avoid the hazards of genome editing technology and capitalize on the potential of the technology in the future. For this reason, this resolve has the support of Maine's Public Research University. While we defer, thank you. While we defer to this committee on the final makeup of the advisory panel, the University of Maine has both great knowledge and interest relevant to its responsibilities. We welcome the opportunity to both serve on the panel and to provide additional technical expertise as necessary to inform its work. Thank you for your consideration, and I would be happy to answer questions.
Questions from the committee? Seeing no hands up, thank you for being here today. And we will next hear from Derek Hernandez. Welcome.
Yes, hello, good afternoon, Senator Claxton, Representative Meyer, and other members of the committee. My name is Derek Hernandez, and I am a Colby College senior from New York City. I am testifying in support of LD 1601 because CRISPR is the reason why I came to schools such as Colby and why I chose to study abroad at Bigelow Labs. When I first learned about CRISPR my junior year of high school, I instantly fell in love. Having the capacity to genetically edit organisms, as well as seeing the results relatively immediately, was fascinating for me as a young kid from a low-income neighborhood. Growing up, I was strongly advised by my mother to go to school and do my best. Without having guidance, I had no idea what I wanted to do or what could be done with an education. CRISPR solved that problem for me. It filled me with curiosity and a poise to better understand and study such a phenomena. I have had the honor of working with Dr. Fernandez Robledo on a CRISPR project focusing on enhancing the process of successfully genetically editing an oyster parasite, as was heard from Asha. Through this project, I successfully achieved one of the first goals I set for myself before coming to Kobe to get published. Simultaneously, I also have my own project that I've been working on for 3 years at Kobe, which is also a CRISPR project that has the goal of altering the body pigmentations of bugs that are commonly found in our backyard. Though I never fantasized about studying oyster parasites or bugs in our backyard, knowing that such research will help us better understand these organisms along with human benefits such as biomedical implications was revolutionary for me. All this goes to say that CRISPR is capable of producing groundbreaking research, not to mention CRISPR receiving its first Nobel Prize in December 2020, while also serving as an inspirational scientific practice for young adults and instructors. CRISPR provides people with a practical alternative to some of the big questions and problems we face as a society. Moreover, CRISPR allows us to answer the what if and what if not questions with results relatively efficiently. Furthermore, these impacts of CRISPR not only supplement the multitude of reasons of why genetic editing is important for society, scientifically, economically, politically, and individually, but you've also heard some of the other reasons from previous speakers, and you'll hear more of after me. Thank you for your consideration. I will be happy to answer any questions.
Thank you for your testimony. Seeing no hands up from the committee, we would welcome Frank Chessa.
Good afternoon, everyone. Senator Claxton, Representative Meyer, distinguished members of the Joint Standing Committee on Health and Human Services. My name is Frank Chessa. I'm Director of Clinical Ethics at Maine Medical Center, and I'm here to testify on behalf of Maine Health in support of LD 1601, resolved to establish an advisory panel to study the implications of genome editing technology for the citizens of the state. New technologies, when they are powerful, and CRISPR certainly is powerful, typically bring with them both great promise and great danger. We've heard already about some of the basic descriptions of what CRISPR can do, and in particular about some of the great things it can do for medical advancement and treatment of human disease. So that's wonderful. I think I'll focus on kind of spin-off technology from CRISPR that highlights some of the great danger of that technology. So this is called gene drive. And let's say that you want to create a species with a particular characteristics, and we can go with famous from this history, red-eyed mosquitoes. So you can use CRISPR to insert the gene for red eyes, but then you can also insert a second gene that essentially tells the body to find genes that are not for red eyes and replace them with genes that are for red eyes. Then when that mosquito, which has those two genes, reproduces, that essentially that second gene, a search, destroy, and replace gene, goes out and finds all the genes for not red eyes and replaces them with red eye genes. And what that means is that trait will move through the population of mosquitoes as they reproduce very, very quickly. And for a species like mosquitoes that reproduces with many offspring in a short time cycle, it wouldn't take very long for that entire species, really across a country or across a globe, to have that new trait of red eyes, which if you think about it, it's quite revolutionary to, through human intervention, to be able to change a naturally occurring genome in one species and totally alter it.
30 seconds, please.
Yes. So, that I think highlights why it's important to have a panel such as this to take a thoughtful approach to gene editing. It's important for medical advancements. It's important for future medical treatments for people in Maine. It's important for Maine agriculture, but it's also important that we think about appropriate regulation so that this easy to use technology is appropriately regulated. So we're thoughtful about how it's used before we do something that we really can't turn back in terms of changing a species. So thank you. Thanks for listening, and I'm happy to take any questions.
Thank you for your testimony. Seeing no raised hands, we will move to Jennifer Jewell. Welcome.
Thank you for having me here this afternoon. Good day, Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. My name is Jennifer Jewell. I am a resident of Portland, a pediatrician, a member of the Board of Directors of the Maine chapter of the American Academy of Pediatrics, and a concerned citizen. I'm testifying in support of LD 1601. We can all agree that many human diseases are a direct result of a person's genetic code, meaning that despite healthy living and advantage, the diagnosis is inevitable even before birth. We live in an era where novel technology has provided a mechanism to cure a number of these diseases. As a pediatrician, I have witnessed tragedy for children and families that are impacted with many of the disorders that genetic innovation may be capable of routinely curing in the extremely near future. I have seen toddlers with sickle cell disease suffering the lasting effects of an all too common stroke, an adolescent who could walk and now is confined to a wheelchair, understanding that this is the beginning of the end of his life due to Duchenne muscular dystrophy. Young adults with cystic fibrosis requiring double lung transplantation, hoping that their life expectancy is closer to 10 years instead of the more typical 5. The family devastated by the early death of a parent with Huntington disease, and parents and patients of all ages knowing that total blindness is approaching. While I can recall the impact of all of these conditions on specific patients and families, the contribution to the increase in healthcare expenses and social support programs is unimaginable to me. However, any new technology, especially ones that edit genes, must be done with caution and with input from experts in ethics, medicine, research, public health, and the environment. My concern is about nefarious uses of these technologies to create biologic weapons and promulgate physical and cognitive traits that our society finds desirable. Therefore, genome editing technology cannot be left to a single group of professionals. Instead, understanding the implications and establishing boundaries requires a transparent process to consider all of the short and long-term impacts of genome editing. Establishing a panel as described in LD 1601 does just that. I look forward to a day when I no longer sit in a room with a box of tissues delivering devastating news to a patient and family that a child has a disease, resulting in a life of emotional pain, physical suffering, and financial ruin. Being capable of curing these genetic diseases will positively impact individuals, families, communities, and our state in so many ways. Establishing the proposed advisory panel will allow this to be achieved comprehensively and ethically.
Thank you, Dr. Jewell. Questions from the committee? Seeing none, we will move on to Dr. Fernandez Robledo. Welcome.
Good afternoon, Senator Claxton, Representative Myers, and other members of the Health Committee. I'm Dr. Fernando Robledo. I'm honored to testify on behalf of Bigelow Lab in support of LD 1601. When people ask me what do I do for a living, I tell them I'm a scientist, in particular a molecular parasitologist and a genetic engineer. As a research scientist, we are often confronted with complex questions in a dark box. Now imagine a microscopic organism growing in a flask. I do talk to them, but they do not speak back to me. We need a new language. That language is DNA. The 4 letters that when they put in a particular order, they make all the living organisms that we see in our forests, in our mountains, in our coasts, in our villages and cities. However, just reading them aloud is not enough. We need a way to decipher those sounds, and we solve them by using molecular tools. CRISPR is one of the best things that has happened to us. It is a tool from nature. We did not invent it, we discovered it. Before CRISPR, genetic alteration in living organisms was mostly achieved through selective breeding and random mutagenesis, which can take years, if at all possible. Now, with these new precise genetic tools, we can eliminate the random component and target desired traits in a secure, ethical, and sustainable manner, and in a matter of days or weeks. I spent most of my career learning about parasites of oysters and how to engineer them for biomedical applications. I've been developing tools to interrogate the parasite genome, and CRISPR is one of them. I'm studying oyster parasites to develop vaccines for people and for animals. I also teach synthetic biology, a discipline that introduces the students to the latest gene editing tools and the ethics involving their use. 2 years ago, a teacher from the Center for Learning and Teaching in EdgeCom reached out to us because he wanted help with a hands-on lab using CRISPR. One of the things I will never forget is the face of the 8th grade when they were pipetting the CRISPR components in a tube. They were not watching a sci-fi movie. They were learning the ways of the future in biological sciences. When you meet to work this bill, I want you to think of them, their future, our future. I saw in their eyes the next nature tool waiting to be discovered. Let them pursue that dream here in Maine. Thank you for your consideration. I'll be happy to answer any questions.
Thank you for being here today. Seeing no hands up, we'll hear from Thomas Brewster. Welcome.
Thank you.
Thomas Brewster. Would you like to unmute? There we go.
You got it?
We're halfway there. We can't see you. We can hear you.
I can't either. Okay. Okay.
Welcome.
So Senator Claxton, Representative Meyer, and other honorable members of the Health and Human Services Committee. My name is Dr. Thomas Brewster, and I live in Portland. I am testifying in support of LD 1601. This is an extremely significant topic. The field is moving so quickly, there is a need for transparency and public dialogue, even for the scientists in the field. The structure of DNA, the basic blueprint of cell function and reproduction of all organisms, was identified in 1953 by Watson and Crick. This was soon followed by the determination of the DNA code for gene structure and function. A less famous molecule, RNA, is necessary to carry out the instructions for making proteins from the genes encoded in DNA. In 2012, Doudna and Charpentier identified an RNA structure known as CRISPR-Cas9, which can insert, delete, or edit the genetic code of DNA in every species on Earth. To treat many diseases, CRISPR offers the potential to edit and repair mutated genes directly in human patients. Because CRISPR allows precisely and relatively straightforward DNA editing, it has transformed every genetic disease into a potential target. Physicians have already begun treating some cancers with immune cells whose genomes have been edited, and gene therapy has resulted in life-changing treatments and in some cases, life-saving cures. The Maine Newborn Screening Program was established in 1965, initially to identify infants with PKU, which causes severe mental retardation if not diagnosed and treated in the newborn period. In 1978, after completing a fellowship in genetics at Boston Children's, I came to Maine and established a clinic at Maine Medical Center for newborns with rare inherited metabolic disorders. The newborns were identified clinically or through the state newborn screening program. By 1978, 3 more conditions had been added to the screening panel, and the treatment was consisting of dietary measures. At present, over 30 conditions are now being screened through the Maine Newborn Screening Program. New conditions are being added due to breakthroughs in laboratory and treatment technologies, such as gene sequencing and gene therapy. Recent examples include drug therapy addressing the basic cellular defect in cystic fibrosis and gene editing to treat sickle cell disease. There are profound implications of gene editing and therapy. It can be used not only to treat diseases in patients, but also to prevent diseases in future generations. The CRISPR-Cas9 technology is so simple and efficient that it is possible to edit the germline, allowing the transfer of genetic information from one generation to the next. it is possible to sequence the whole genome of a newborn from the screening filter paper spot and identify pre-symptomatic inherited conditions which express themselves in adulthood, such as inherited cancers and heart disease. Early identification would allow measures to prevent the onset of disease. The technology is developed to the point that a division of genomic medicine should be established within a healthcare delivery system in Maine. Such a division should collaborate with primary and secondary care, genetic counselors, clinical and research labs, CDC, and companies with interest and expertise in pharmacogenomics, artificial intelligence, bioinformatics, biobanks, gene sequencing, and somatic cell editing. The future is now. And I'm happy to answer any questions.
Questions for Dr. Brewster? Seeing none, that concludes testimony in support of the bill. Testifying in opposition is Matthew Rhodes. Matthew?
Yep, I'm getting unmuted here and I'm
All righty.
working on turning on my video somehow. Okay. I apologize.
That's quite all right. We can hear you. There you go.
Hi, how you doing?
We're well.
I'm a little bit of a Luddite, all this technology and everything, I like the wheel. The wheel's a good thing. So the reason I'm here today is that I stand in opposition to this bill, and I don't want to disparage anybody's good intentions and stuff like that. I studied under a professor at the CDC in Washington, D.C. when I was in college, when AIDS was an epidemic. I was a lab assistant all throughout junior college, and I have 2 years of pharmacology and microbiology. I also was a lobbyist for the FDA. So my background is that we talk about all these great positive things, and nobody wants to die, and nobody wants anybody to suffer. But what the scientists don't tell you is that the lab that it took to create us took millions and millions of years. And the lab that it takes to discover these things might only take, a couple of weeks, and we can see immediate results, but we can never understand the long-term synergistic effects at the subatomic level of what is happening to the human race. We all get very, very excited about this stuff, but I'd like to point out that people were excited about thalidomide, and we know what that did to human beings. We know what pushing antibiotics in people, particularly to my immune system in the 70s. I was born with immune system disorders, and they didn't discover that till the 90s. And in the meantime, I got pushed with antibiotics, and that ruins you worse. So this stuff comes along, it's novel, people get very excited about it, and they think they're going to save humanity. And in the end, what they find out is they've created superbugs, or they've created a race of genetically disabled people. And so everything that was approved by the FDA has been repealed by the FDA. So in terms of the medical community, we have to, as scientists, be honest about our results. And our results have not always been very good. That's the most honest thing that we could say. We can be very excited about it, but we have to be honest about it. And then, and somebody was talking about the mosquitoes in Florida. I want to point out, if you've ever driven a tractor trailer through the state of Florida, there's a genetically made bug called a love bug, and it's black, and it's got a tarry kind
30 seconds, please.
Thank you, ma'am. It's got a very tarry thing, and they can't get rid of it. And all it does is fly around and reproduce and destroy everything that's around. And then I want to say that in everything else, herd mentality is not a good idea. You could be going the other way and still be doing just as good, versus everybody doing this. If you're doing the other thing, you might be doing the right thing. So I would hope that you guys vote against this until we understand human genes much, much better than we do now. And thank you very much for having me, and thank you guys for being such hard workers.
Thank you for being here today. Questions for Mr. Rhodes? Seeing no hands up, we will move to testimony neither for nor against and welcome Judith Sayers.
Good afternoon. Senator Caxton, Representative Meyer, and other honourable members of the Health and Human Services Committee. My name is Judy Sayers, and I'm a graduate student studying for a PhD in chromosome and developmental biology at the University of Oxford. I am testifying regarding LD 1601 in order to provide a perspective from a junior bench scientist on a topic of global scientific importance. CRISPR-Cas technologies have greatly facilitated my lab's ongoing research into mechanisms of heart regeneration and repair. We aim to understand how the heart responds to serious heart injury, such as a heart attack. Our research supports the design of regenerative therapies to prevent heart disease, which remains the foremost cause of death in the developed world. CRISPR-Cas is now a very important part of the toolkit available to geneticists and biomedical scientists in the laboratory, as you have heard, used on a day-to-day basis in wide-ranging research questions. This technological development has made gene editing very significantly cheaper, easier, and quicker. Ongoing developments are, of course, rapidly expanding the range of applications that CRISPR may be used for in the lab. In particular, alterations to the Cas enzyme, which is the molecular scissors that actually cuts the DNA, allow CRISPR to be used to edit the genetic code with unprecedented precision and in new ways. I think that these developments have huge promise going forwards. The CRISPR-Cas system may now be used to perform a range of subtle genetic and epigenetic alterations on a very wide variety of species, efficiently and quickly, expanding the ways in which we may study and therefore combat disease in the lab. As early career researchers, my colleagues and I, working in laboratories across Oxford in the UK, discuss and stay abreast of ongoing developments in the CRISPR field and take a very active interest, firstly in their applications to bench biology experiments, but more widely, and particularly to their applications in healthcare. So with that, I'll close, but I thank you for your consideration and would be very happy to answer any questions that you may have.
Representative Craven has a question.
Thank you, Madam Chair. Not really, but I wanted to say that I just love this Zoom thing where we can have people from Oxford come and teach us things. Thank you.
Thank you. Representative Zager.
Thank you very much, Madam Chair. Ms. Sayers, thank you very much for zooming in. If I understand correctly, could you, you're saying that your lab is using CRISPR technology to help people recover from heart attacks, or in hopes that one day that can happen?
The latter, exactly. So it very much supports our ongoing research. Our research is at what we tend to call the discovery stage. So in order to cure something as complicated as heart disease, inevitably one has to understand the underlying mechanisms first. And so my lab is a fundamental biology lab as opposed to an applied clinical lab. And so we use CRISPR mainly to try and understand how the heart responds to injury. And it is hoped that that knowledge will then translate to allow us to develop therapies to treat heart disease. So exactly.
Appreciate it. Thank you so much for the clarification.
Thank you.
Senator Claxton.
Thank you for being here and bringing your expertise. In the UK, is there an ethics committee or a studies ethics committee that your studies have to be run through, even though they aren't directly clinically applicable yet? Is there a group that you have to get approval from to conduct your research?
Yes, so I think it's probably worth saying firstly that at the moment, regulations do differ quite a lot in different places. So there's EU regulations, there's UK specific regulations, and then as we've heard, there are US regulations. And in the UK, as in lots of places, there's a lot of ethical regulation, which one has to pass through in order to perform any kind of animal experiment. And so my lab working on animals, therefore, has very rigorous ethical procedures to make sure that animals are only used where it is absolutely necessary. And alongside that, there are various different regulations. But I don't think I can speak very exactly on the status around CRISPR because it's a fast moving field, to be honest.
Follow-up question?
Sure.
Have you looked at the list of people in the advisory council that has been proposed in this legislation? It's quite extensive, and I wondered if you had some sort of similar resource for you, a broad multidisciplinary group of people, including ethicists and religious folks that were a resource in your work or before you started your work.
I don't know of anything quite comparable, which I referred to personally. I think I hope that answers the question.
Good luck with your research. Thank you for being here.
Thank you very much.
That concludes questions and testimony. So I would ask the committee if they've got any requests for additional information from Aaron Dooling. Seeing none. Yes, Senator Claxton.
I've got a quick question. I know that this is not a typical bill in a lot of ways for the material it covers, but I was wondering if we have some experience from other states with similar sorts of panels that we might verify the membership against, or we could understand historically how they've worked. It might be a resource to this panel.
And Representative Zager.
Thank you, Madam Chair. I would point that at Washington State and California, Washington State is considering a very analogous bill, and they've published their proposal. They're a bit more advanced in their structure. They have I guess more of a community of collaboration, scholarship, and government there. And California has looked at CRISPR, but it was it basically outlawed the do it at home CRISPR kits that enable people to create drug resistant organisms at home. But no other state that I've seen, and I've checked with the National Council of NCSL. They weren't aware of it, nor was the National Council of Physician Legislators aware of anything else like this that Maine is considering and Washington State is considering.
Thank you.
Thank you. Seeing no other hands up with requests for additional information, I would ask Erin if there's anything else on our agenda today.
Just scheduling after this.
Yes. So with that, I would entertain a motion. Yes, Representative Zager.
I apologize. I don't mean to monopolize the microphone, but I just wanted to bring to the attention of the committee that we voted on a bill earlier today, LD 843, without hearing from the sponsor, so perhaps we could find a time or consider reconsider that if at some point when the sponsor could be available to address concerns that were raised in our work session. This was the bill looking at trying. It was a resolve.
Yes, LD 843.
843, yes, the resolve regarding homeless students, homeless youth.
So, is that a motion?
I move so. But I don't know if the sponsor, we could see if the sponsor is available, but I don't know if Representative Morales is available at this moment, or if the committee is even moved to reconsider it at this moment. We've had a long day.
That we have.
Since we're going into a scheduling session, how about if we see if we can find a spot that might be workable in the calendar for the next week that we'll be working on.
circle back to you and to the bill sponsor. So I would entertain a motion to adjourn.
So moved.
Second.
We will see you tomorrow morning.